Kia pā tutu tapu e pūtiki tia nei, e te kāpuni o te wairua, ki runga i a koutou. Nā koutou anō e whakatako e te roko hanga o te araha ki te iwi, aumi e, hui e, tae e ki e. Ka tangi kau mo te iwi ngaro, ngaro me te ngaro e te moa, ka tae te aho aitua e, matatu e, he tangata, toi tū te whenua. Whakatau mai ngā iwi, whakatau mai ngā mana, whakatau mai ngā reo. Whakatau mai ngā mātā waka e hoi mai ki konei, ki te tātahi o te waitamata, nau mai hara mai. Nau mai hara mai e ngā tāku te me ki, moa pōpō. O tira e ngā mātanga kai kōrero mo te ata nei, Professor Boyd Swinburne, aroa mai. Me te Professor Ashley Bloomfield, tāku ta rānei, mihi atu ki apue. E kore e tae te kau e nei te roa tēnei tū, no reira waiho e nei runga e nei kōrero a ngā waka ngā reo, ngā hapu kā rangaranga ranga tira e wānga nui i a tātou, tēnā koutou, tēnā koutou, tēnā koutou. E noho. Anō reira ape te hono o tātai hono te honga mate ki te honga mate. Ape te hono o tātai hono te ongo ora ki te ongo ora. E tua atu tēnei ki te whakatau nei i a koutou te me ki, te kaumātua o tēnei pare wānanga. Nō reira tēnā koutou, tēnā koutou. Pai mairiri kia koutou. Kia ora.
Tēnā koutou, te kaumatua rawari, mō tō karakia, mō tō mihi, kia korua, ngā kuia, ngā mihi nui. Ki ngā tauira, kia tātou katoa, i tēnei wā. Tēnā koutou, tēnā tātou katoa. Ko Oharangi Boyd Swinburne, ahau, ko ahau kai whakahaere e tēnei kaupapa, whakahira Population Health Intensive Week. Nō reira, tēnā koutou, tēnā koutou katoa. So kia ora tātou, thank you very much indeed for the mihi and for opening us for this week. It's a big week for the students, so they need that kind of boost at the start to get them through the week, because this thing is called Population Health Intensive, and it is super intensive. They're going to learn a lot in this week, and we're going to have a lot of fun in the meantime. All right, so I'm just going to give you a couple of slides just to quickly introduce you to the week before we get on to the main piece of this morning, which is presentation by Ashley Bloomfield. And you can see in this list of aims here about population health intensive, it's about thinking, a different way of thinking, a new way of thinking, being able to think upstream as to what's causing, what are the determinants that are causing people to come through your hospital doors, the causes of the causes of the causes. Thinking of health in terms of groups, as well as the individuals that you're used to. Prevention, promotion, protection, the fence at the top of the cliff type of analogy, thinking about inequities which drive our statistical health inequalities, which are highly prevalent in this country, the environments which determine our behaviour to a large extent, and systems and policies which create those environments. So a lot of different ways of thinking, and I really hope if you're going to get anything out of this week, it's having a new set of spectacles that you can put on to look through the problems that you're going to interact with throughout your career with. And I have to say that most of you will end up in clinical roles in medicine. A few will go on and do public health as a specialty, but I can guarantee that all of you throughout your career will shift towards population health thinking. Once you're over the hump of learning how to be a doctor and do all that expertise that you've learned, your head comes up above the parapet and you start to see what is causing all the problems coming in through your doors. So you will all take a journey throughout your career towards population health to some degree or other. Okay, so we're going to learn to articulate a population health approach. So those terms, public health and population health, tend to use them a bit interchangeably. There's a bit of confusion when you talk about public health to lay people. It tends to get a little bit confused with the publicly funded healthcare system. So I tend to use the term population health to a large degree. You're going to apply these principles to specific health issues that you've been given on your groups. We're going to, in the next session, learn about the population and personal health approaches and how they're complementary from clinicians who will be who operate in the public health space as well. Key challenges for improving the health of populations with limited resources. So we're going to give you 1 week to try to sort out problems that we haven't been able to solve in decades. But you're a bright bunch, so we're expecting big things. And we're going to create an upstream intervention to try to influence this complex health problem you've been given. So we're starting today with a keynote presentation from Professor Sir Ashley Bloomfield. We'll have some Q&A after that. We'll finish at 10:30. And we'll have, following a half-hour break, we'll have an hour and a half of a panel discussion with 3 clinicians' views and their story from this interface. So we have Dr. Hinemoa Elder, who's a psychiatrist, Dr. Jen Russell, who's a paediatrician, and Dr. Penny Milsom, who's a paediatric surgeon. And all of them have 1 foot in the clinical camp and 1 foot in the public health camp. Then we'll have a session back here with me on what this week is all about, looking at the timetable, expectations, the project, people who want to go for distinction, that sort of thing. So we'll have a session there. And then you will meet with your group facilitators to learn about your project and start working that through. Tuesday, Wednesday, Thursday, you're meeting with agencies, researching your topic. I'll go through more of that detail at 1 o'clock. Wednesday, we have a population health and action session where you learn from public health physicians what their day jobs are all about. What is this public health medicine job all about? And then on Friday, you'll get to present your strategy to one of 5 teams. So it's about populations, it's about population health, and it's intensive. So you'll be working long and hard over this week, just to remind you of that. We've got the other regions on stream at the moment, and they'll be streaming in for today. They will have their own population health in action sessions in their region, except for Pukawakawa, who will be beaming in to us on the Wednesday in Auckland, because they are rather short of public health physicians up in Northland, unfortunately. So for today, we've got students who will be introducing our speakers. So I'd like to thank those people for putting their hands up for doing that. Just to keep you on your toes, I'm going to ask a random person in the room, hopefully they're in the room if they're from Auckland, to ask Ashley the first question, the first intelligent question for the Q&A, to get that rolling. And at the end, I will ask another random person to thank Ashley. So just to let you know about that, and we'll do that the same, at least in our group in Auckland, for the population health and action. So pay attention, folks. All right, those people in the regions and on YouTube, you should be able to, you're going to need to sign on to your YouTube account, and you're able to put questions in the chat, and we have Anna, who is monitoring that. Have you got onto your chat, Anna? Yep. Okay, Anna's in. So those online, if you can register in through your YouTube account and put any questions in there for Ashley when we're done. All right. Now, just while I get Ashley's slide up, if I can ask Harrison Bell to come down and introduce Ashley. Thank you. Harrison, go for it.
Morning, guys. It's nice to see you all in person again. So I have the privilege of introducing our first speaker. Most of you will probably recognize him. He's a pretty familiar face. Seen all the time at his 1 p.m. COVID briefings during the pandemic. He's a doctor, a professor, and a knight as well. His career began much like ours after graduating from the University of Auckland. He started out as a public health registrar, eventually working his way up the Hutt Valley District Health Board and becoming chief executive, and then going even further, becoming the Director General of Health in 2018. Then just a short 1 year into the job, he was thrust into the helm of the pandemic response, and I think he handled that pretty well. I mean, that might be controversial, who knows? After passing on his role as Director General, he's currently working as a professor, hence why he's here today, I assume, to share his expertise, and he's also the co-chair of the World Health Organization Working Group on Amendments to the International Health Regulations for the Ministry of Foreign Affairs. Please welcome Sir Ashley Bloomfield.
Well, kia ora koutou katoa. Not a COVID-19 announcement, you'll be pleased to know. Harrison, thanks very much for that generous introduction. I'm very thrilled with your assessment of my performance as Director General of Health. I have to say that was a lot easier than the 1 o'clock stand-ups, which felt like a sort of a live performance review on television every day. It's very nice to be here, and for the students who are beaming in from around the Motu and the regions, great to have you online as well. It's a long time since I sat in this lecture theatre. Next year is 40 years since I started medical school, which is a slightly horrifying thought. The only thing that's the same is the sign up the front there you can see about no drinking and eating. It looks like it's 40 years old, 40 years older than it was. But it is nice to be here. I hope you get something from my talk today, and in a way Harrison's done a lovely summary of it, because it's essentially my journey in medicine and in population health as well. And I just want to tell you some stories about what's happened through my career, because I didn't go from sitting in this lecture theatre to Director General of Health, obviously all in one smooth movement. It had ups and downs and the usual things that life journeys have. When I first started my public health training, I did my Masters in Public Health in Auckland here, and I then went on to work at Auckland Regional Public Health, 1997. And we had a measles outbreak in Auckland. This measles outbreak had been predicted based on the level of vaccination and of children and of different cohorts coming through. But unfortunately, the outbreak started 3 months earlier than the vaccination campaign that was designed to prevent it. We didn't stop though. We did two things, a bit like our response to COVID. First of all, we controlled the outbreak here in Auckland, but secondly, we brought forward the vaccination campaign, and there were just over 2,100 cases and 2 deaths. We brought forward that vaccination campaign, and this is the thing about measles, that if you vaccinate even in the middle of an outbreak, you prevent a whole lot of cases, and obviously the attendant hospital admissions and deaths. And it's estimated, we looked back and wrote a paper about this and estimated we'd prevented 90 to 95% of the cases that would have happened if we hadn't cracked on with the vaccination campaign. Well, 2019, I found myself down in Wellington, Director General of Health, and deja vu. We had another outbreak here in Auckland. Very similar number of cases. You will notice there quite a high hospitalisation rate. which I think suggests a very low threshold for hospitalising unwell people, particularly children. No deaths other than 2 pregnant women who unfortunately lost in their 3rd trimester fetuses, but no deaths in children, some of whom are very unwell. But the terrible thing that happened, we have a deep connection, as you know, with the Pacific, and the virus got to Samoa. Now, a few years earlier in Samoa, 2 children had died very quickly after they'd been vaccinated with MMR. And as it transpired, the nurse who did it had used the wrong diluent and to make up the vaccine. But what had happened is that this had really undermined confidence and trust in the vaccine. And so their vaccination rates were unfortunately very low, down around 30%. So you can see what happens. A small country, Samoa, over 70 deaths, many of them in infants and young children, a reflection not just of the low vaccination rate, and so lots of cases, but also of the fact, of course, of a much less well-off health system without the capacity and capability to look after all those unwell children. So this was a disaster, nothing short of. And of course, just to fast forward to 2020, the memory of this was very fresh in my mind and in the mind of many of my colleagues. And one of the things that drove our COVID response was we wanted to be absolutely sure that the coronavirus did not get into the Pacific through New Zealand. It was a key driver of our response here because we had seen what had happened when this happened. And we knew, just as we knew in Aotearoa, that the communities that would be hardest hit were Māori and Pacifica and older people and disabled people, our marginalised communities, those who are homeless or with mental health and addiction disorders. We knew also if the virus got into the Pacific, what would happen. So that was a huge lesson for us there. So measles was, the first paper I published as a public health registrar was on this measles outbreak in Auckland. And then it felt, as I say, like deja vu. In the interim period, I had specialised in non-communicable disease prevention and control. Pretty handy when you then get a pandemic of an infectious disease. But the principles of public health and population health are the same. And furthermore, and I'll make this point right at the end, is every experience you have in your career is building your knowledge base, building your skill set. So make sure you focus on what you can learn. In 1997, I decided to go to Wellington for 6 months to do some policy work to round out my public health medicine training. So up sticks my poor wife. We had a 5-month-old, our first child. She had to leave her family behind here, and we went down to Wellington, lived up on the hill in Johnsonville, and got absolutely pummeled by the legendary Wellington nor'wester wind. I think at one time we couldn't see out through the clouds for 5 days. But I did learn a lot, and one of the reasons I learned a lot is the very first project I worked on was on this document, and it's still available online. You have to search for it, but I will circulate these slides afterwards, so you can, if you haven't got them already. I know you like to have the slides, so I know you will assiduously follow up all these links and read these reports. But this was a wonderful piece of work. For those of us who were adults in the room at that time, you may remember that through the 80s and 90s, of course, New Zealand, there was a big swing economically to a neoliberal perspective, managerialism and in the public sector. And this quote here about poverty not really existing in New Zealand was from one of the prime ministers in that decade in the 90s, that actually New Zealand didn't really have any poverty. And of course that person, he was referring to absolute poverty, which of course is the people living on less than $1 or $2 a day in Africa or in very, very low income countries around the globe. But rest assured, there was and is poverty in New Zealand. And this report, which I was privileged to be the main pen holder on, and I worked with some wonderful people, some of whom you will know and are still here, but Alistair Woodward chaired the advisory group around this, and on the National Health Committee were people like Mason Jury, who were very influential in shaping this report. And it was one of the key reports that really kick-started and supported a conversation around equity, inequalities in health, poverty, and the determinants of health. And for us personally, after, we went to Wellington for 6 months and we're still there 25 years later. And the reason for that was I found, for me, I really found the flow when I was working in the public service. I just loved being in the public service. And that nexus between public health and the public service and that political policy interface is I just found so stimulating and interesting that we decided to stay. So 6 months has become 25 years. And Wellington is our home now, but I'm enjoying spending more and more time up here in Tamaki Makaurau as well. And just a word on determinants, and I've linked you to an article. This is what professors do. They cite references to their own work. I've learnt over the years. So this is an article I published in the Millbank Quarterly pre-pandemic when I had time to think and publish, which was after New Zealand's first wellbeing budget delivered by by Grant Robertson in his first year as Minister of Finance. And the proposition in this is actually, I think we should move away from what I think is quite narrow language around determinants of health. And in the article, the reasons I put forward to this are, actually, I can tell you people in Wellington and around the world, in Wellington I'm talking the policy sector, don't walk around talking about their area of work being a determinant of health. They just think about well-being. And health is a really important outcome, of course, for all our work and for the work of governments. It's a really important outcome. But it's also a really important determinant in itself of well-being, of social and economic well-being, of people being able to achieve what they want to achieve in their lives. So I've started talking about the determinants of well-being, hasn't caught on yet. Meanwhile, the list of determinants of health gets longer and longer and longer. But we've got to be careful we're not just talking to ourselves around this. I stayed in the National Health Committee, which is where I started doing that work for a few years, and my first leadership role was managing that secretariat there. Got to be involved in some really interesting work around primary care. All these reports are available online still. The very first report on population screening for colorectal cancer, one on improving Māori health policy. Now Professor Sue Kringle down at the University of Otago and Dr. Julia Carr, a fellow health physician, were the lead writers on that bit of work with oversight from Mason Jury and others. A lovely bit of work on people who care for others and caring for the carers. And my first introduction to the health quality and safety area, which I'll come back to. But one of the most life-changing career informing pieces of work I was involved in was a piece of work that we did on disability, people with intellectual disabilities, because the National Health Committee had a brief across disability support services as well. And just remembering the remarkable Anne Bray, who unfortunately passed on in 2008, she headed the Donald Beasley Research Institute on Disabilities in Dunedin. She was an amazing champion, and this wonderful piece of work that worked with people with intellectual disabilities. And the quote at the top was from one of the people who was involved in this, person with an intellectual disability, and it just stuck and it became the title of the report. All I want is just to live an ordinary life. And the subtitle was Community Membership for Adults with an Intellectual Disability. And this report looked at all the dimensions of our lives that we take for granted, but that for people with intellectual disabilities, it needs to be absolutely focused on and curated for them so that they can, to the greatest extent possible, live an ordinary life. In your work, you have already, I'm sure, and you will interact with, in your clinical work with people with disabilities. And it's really important to think beyond to just, of course it's important with everybody to think beyond just the presenting complaint, the disease system. But for people with disabilities, their everyday lives are often disabled by the way that societies are constructed. And so really think hard about not just what is the medical, what is the health issue that's in front of you, but what are their support needs that are going to help them get back to where they want to be, which will be, if nothing else, just living an ordinary life. One of the bits of work I got involved in the National Health Committee was around screening. We did, I think, a really great report that provided some criteria for how to assess whether or not we introduce screening programs in New Zealand. So on the advice of one of my managers and mentors at the time, Dr. Gillian Durham, a wonderful public health doctor, served many years in New Zealand, she said, well, why don't you go and work in the screening unit for a while, which was a sort of a little bit of a challenge, because at that time there had been quite significant problems in our breast and cervical screening programs over many years. And we were on the front page of the newspaper or on lead story in Morning Report most weeks. I guess this was my first introduction to having to front the media on issues. Not a bad training for what came later. But the difference, of course, between screening and clinical medicine is in screening we're offering well people a test. And the quote here at the top is from one of the I think, global leaders in thinking and in delivery around screening programs, a Scottish public health doctor, Sir Muir Gray. Look him up, he's just fantastic. He's done all sorts of different stuff in his career. He's still active. But the quote here is, all screening does harm, but some does good as well. And now that might seem a bit counterintuitive, but the key thing here is with screening, whether it's offering a mammogram to a woman or a cervical smear, or sometimes people use a prostate-specific antigen blood test to see if someone might have prostate cancer, all screening potentially does harm because you're taking well people. And of course, no screening test is 100% sensitive and specific, is it? And so you will always have some false positives, and those people then have to go through investigations, and it causes anxiety and fear. And sometimes those investigations can have their own physical health implications. And then, of course, you don't detect every disease with most screening tests. So you will have false negatives as well. And those people can be falsely reassured and not maybe act on symptoms that might come along. So think about that with screening. And the other thing about screening is it doesn't necessarily prolong life. It just may prolong the period with which someone knows they've got a disease. And this is particularly so with prostate cancer, where most men die with prostate cancer rather than from it. And many incidental prostate cancers are found once men die from other causes. So you may or may not be looking at screening this week. One of the groups is one of your assignments, and you've probably looked through this. But as clinicians, you will be involved. Many of you will be involved in some part of a screening program. I had a number of highlights. We introduced universal newborn hearing screening. Seems odd that these things weren't already in place, but they were big decisions. They required investment. Routine antenatal HIV screening wasn't in place until about 20 years ago. Antenatal screening for Down syndrome, and myself and the wonderful Dr. Susan Parry, who you may well know, a great gastroenterologist in South Auckland, when there was no interest really in colorectal cancer screening, we sort of kept this tiny spark alive. Every now and then we'd reconvene the advisory group to look at the evidence, and eventually the government did invest in, and we now have a nationwide screening program for colorectal cancer screening, and the full circle for me was the first DHBs to introduce that were Wairarapa and Hutt Valley DHB, and I was the chief executive when that got rolled out from Waitemata into the wider rollout. So screening, a really important part of both population health and clinical medicine. So one of the real privileges I had was from 2005, Professor or Dr. Don Matheson, another public health doctor, was a boss and a great mentor, started to involve me in the delegations attending the World Health Assemblies in Geneva at the WHO. And this was both exciting and hugely a huge privilege. The very first meeting I went to was the final 2 days negotiation of several years of negotiations on the International Health Regulations 2005. And just the final bullet point there, you might have heard in the introduction, I'm now co-chairing the revision of those regulations. Here we are all these years later, nearly 20 years later, and this is following the pandemic. They need to be strengthened and improved and brought up to date. I'm co-chairing that process with a great public health doctor, Dr. Abdullah Asiri from Saudi Arabia. It's quite a process, 5 trips this year to Geneva. 196 countries, 307 amendments to agree what could possibly go wrong. But these things do take a long time, and as you can see, the last day kept going, and we finally finished at 4 a.m. in the morning. But that's what often it takes to get consensus. And this is a quote from one of the meetings I was at, and it was a US delegate, senior US delegate, I think during the time of the Bush administration, and there was a lot of toing and froing on a particular matter around, I think, sexual and reproductive health. And he said, look, consensus or getting compromise is a result that no one fully likes, but that everyone can live with. And when you go to these meetings, you look at the starting position on some of these issues, and they are what appear to be poles apart, and you think, we're never going to get agreement. But you can, and you do, and this is a really important skill that people are practicing around the world, is to get agreement on really important global health issues, so-called health diplomacy, to achieve consensus. And I got involved in a whole lot of interesting issues, particularly on the non-communicable disease side of things. One of the things I did after the screening unit was I took on this role, which we made up. It was called National Director Tobacco Control, something like being able to sort of define the title of your own job. But one of the areas I'm most proud of and thrilled that I have and still remain involved in is tobacco control. I started when I was still a public health medicine registrar. I was on the board for ASH Action on Smoking and Health. It still exists today, and it was set up by doctors initially in the late 80s, and really helped support the passage of the very first Smoke-Free Environments Act in New Zealand. And the health minister at the time was Helen Clark, who subsequently, as you know, became Prime Minister, then head the UN Development Programme, third most senior role in the United Nations. And she talks about the vitriol that she received even back then. So this vitriol and abuse hurled at politicians is not a new thing. It comes from all parts of society, unfortunately, when people feel that what they hold dearly and what they value dearly is at risk. So it was a very brave move to put this legislation through. She still talks about receiving bullets in letters. We still had a lot of mail in those days. There was no email, so bullets in letters in her mailbox from people who opposed her efforts to protect the health of New Zealanders. It's what happens in public health. You've got to play the long game. But in 2003, you could still smoke in most workplaces. And if you went out, it's well beyond your ken, but older members of the audience will still remember coming home from a restaurant or a pub, having had a night out, and your clothing would reek of cigarette smoke. It was a horrible thing. And in 2003, the government passed legislation to, and Annette King, now Dame Annette King, was the health minister at the time, with quite good support across the House. But interestingly, when this passed, there was less than 50% public support for a ban on smoking in workplaces. The wonderful thing, of course, this created for hospitality staff was a safe workplace, at least from a second-hand smoke perspective. Well, within 3 months of that law being passed, over 70% of smokers, let alone non-smokers, over 70% of smokers supported it. Actually, it's not from it being passed, but from it coming into action, which was a year later, December 2004. By this time, I was the National Director of Tobacco Control, so I was put in front of the media. I did get a bit of experience in this media thing during my career. Rolled out as to speak to this, and I can remember an interview in a pub where they were talking to patrons about this new law that was about to come in. And the most common question I got asked, but who's going to police smoking in pubs? Who's going to stop all these people smoking in pubs and clubs and workplaces? Well, that's easy. And we saw this during COVID. You can't police a lockdown. You rely on the vast majority of citizens who are just decent, kind of sensible people doing the right thing. And what happened when that law came in? Day one, smokers went outside to smoke. There was very, very little issue with the implementation. No one needed to police it. Smokers knew what the law was and they did it. And it was one of a number of things that helped transform our landscape over subsequent years. My shout out in this slide, and I'll show you a slide next that just shows you the impact of our focus on tobacco control over the last 2 decades. But I do need to give a shout out to now Dame Tariana Turia, who was the Associate Minister of Health when a new package of initiatives, regulatory and other initiatives, were brought in, I think about 2010, and these included quite significant tax cuts. And at the time, Dame Tariana, was it? Tax increases, sorry, not tax cuts, gosh. Tax increases, thank you, Boyd. Really significant. And so Dame Tariana, she was the Associate Minister of Health, and we worked with her on this package. And she was the co-leader of the Māori Party at that time. She'd helped establish it. They were in a coalition government with National, headed by now Sir John Key and now Sir Bill English. This is what happens to old politicians, they get a title. And John Key was the Prime Minister, Bill English was the Minister of Finance. And she went and had a conversation with him, and she came, we waited in her office. We'd done a lot of prep, and she came back and she sat down in her inimitable way. We said, "How did it go, Minister?" She said, "Well, I told the Prime Minister and Mr. English that it was very important for my party that they support these measures if they wanted our continued support on supply and confidence issues," which is about as strong as you can go when you're in a coalition government. Absolute political courage. When you introduce tax increases on tobacco, you don't give the tobacco industry any warning, because what they do is they import a whole lot of tobacco just to get a lower excise tax on it for about 3 months worth. It means they save a bit of money. Doesn't mean they don't pass on the increase immediately to customers, but they just rake off a bit more profit in the meantime, which is, after all, what they are trying to do. So when this legislation to introduce a tax increase is introduced into Parliament, it's done under extraordinary urgency. So the Minister, Dame Tariana, just stood up and said, "I'm going to introduce this bill and there is a tax increase that is effective immediately." When she stood to do that in Parliament, there were no National Cabinet members in the House. They had all absented themselves. So she was on her own. But here's the thing. Every party, bar the ACT Party, voted in support of that bill to increase taxes. And even in the ACT Party MPs, amongst them there were 5 of them, one of them voted for it, saying that he couldn't in all conscience vote against it. Many improvements in public health would never have got across the line without extraordinary, often very lonely political courage by individuals. And I just want to take my hat off. And one of the real pleasures is working with people like Dame Tariana and many others I've worked with who have done these extraordinary things that have helped really shift the dial. And look at what has happened to year 10 smoking rates. 2000, probably about when many of you were either being born or just born or about to be born, I think. I've got a son who was born in 2000. But look at that smoking rate, daily smoking rate for young Māori girls, over 30%. And look what's happened in the subsequent 20 years, and that huge reduction in inequality there, in inequity. So for Māori girls, it's gone from over 30%, over 35%, 37%, down to around 3%. And this is what you try and achieve in public health, and it takes time, and you've got to be very tenacious. And in 2018, when I'd just become Director General of Health, I think, the government introduced legislation that came into effect a year or two later to ban smoking in cars with children in them. Well, I can tell you, we started talking to ministers in about 2007 about that. And the evidence did not change. The evidence did not change. But the political window of opportunity opened up. Someone caught Winston Peters on a good day, and he said yes. I don't think he knew what he was agreeing to, but c'est la vie. The next thing, we were able to get that work done and get that legislation passed. So you've got to be in the long game in health and in public health. But very, very satisfying. And just to put that in perspective, you will know this. If you don't remember this, smokers die on average 7 years younger than they would otherwise have died. And that's 1 in 2 smokers. 1 in 2 smokers die early and lose around 7 years of life. So that has saved and will prevent many, many premature, unnecessary, painful deaths in future. Well, one of the other things I got involved in was illicit drugs, not their use. But in New Zealand, you know, we're a small country, so I was involved in a whole lot of different issues: alcohol, tobacco, and illicit drugs. And this included chairing a really interesting committee, the Expert Advisory Committee on Drugs. It's a statutory committee, so it's in legislation. And this new substance appeared, BZP, into what were called party pills. It was before your time. None of you will have probably even, you certainly won't have come across them, and I doubt you'll have used them. But these things appeared, created a market out of nothing. And about 50% of youngish people, late teens into their 20s, used these things. And just like the vape shops now, there were high street shops selling party pills. And they appeared, and there was no way to regulate them at the time. So we had to set about commissioning research to find out what the impact was of these party pills. And again, just a hats off to an amazing Member of Parliament for many years, the late Jim Anderton, who was the Associate Minister responsible for drug policy. And he absolutely held his nerve. Of course, politicians usually react by just banning things, but he wanted to take an evidence-based approach to this. And the legacy it left was a change in the legislation that then allowed new substances to go through a process where those who wanted to sell them had to provide evidence about the benefits, if there were any, and the harms. So Jim, who was a great person to work with, held his nerve. He waited for the evidence. And when we finally came through and the government changed the law and said, that's fine, you can sell these things if you provide evidence of all these things, well, suddenly those who were marketing them, peddling them actually, decided, oh, they didn't have the wherewithal to provide this evidence. And so this market that became huge suddenly disappeared. But the funny thing was they weren't very good anyway. They were kind of self-limiting. The market was always going to be self-limiting. And the quote at the top is, I talked about myself not necessarily being involved in the use of illicit drugs or mind-altering substances for this purpose. But one of our committee members, who was a professor of addiction and a real wag, decided that he would, for the benefit of the committee's research, buy some party pills and take them, and then at the next meeting describe to us what had happened. So he gave us a very dispassionate description, which included, he said, well, there was no real hit like, you get from a nice cup of coffee. And then I was awake, I must have been awake all night, because the next thing I remember, it was morning, and I had this terrible hangover. And this was one of the self-limiting problems with this party pill, BZP, is it wasn't actually very good, and it gave you a terrible hangover. So a lot of people who used them never used them again. But I can tell you this, on that committee were a rep from the police, customs, and the Department of Justice, as well as sort of pharmacologists and others. And they were just sitting there agog as he related this experience, getting more and more uncomfortable, all in the name of science and good policy. I learnt a lot about how to chair challenging meetings. They were always really challenging, and this same person was constantly trying to encourage us to take a look at alcohol and assess it by the criteria that illicit substances are assessed by. And I had to do some very careful footwork every meeting to sort of just keep deferring that, because it wasn't in our brief. And essentially our brief was to do things that ministers asked us to. But I did have something to do with alcohol, the tricky liquid. And in the end, two of the Expert Advisory Committee on Drugs members did, with another colleague, and they're all very prominent physicians in this country, did take an assessment of alcohol and published it in the medical literature, and I've put the reference there. Now, under the drug legislation here, substances are classified as class A, B or C. Under C are things like marijuana. Under A are the substances that are most harmful, methamphetamine and others. And at the end of their assessment, and they put it through the same criteria that we used as an EACD, they classified alcohol as a class B substance, or they said it would be if it were regulated under the Misuse of Drugs Act. This is an incredibly contested area, and you will well know it, for a range of reasons, but here are some of the most important ones. For a start, alcohol is widely used in New Zealand and in many countries around the world. It's not just a small minority of people that use alcohol. This is an incredibly powerful industry. It's multinational. They have got, as the saying goes, more money than God. Very deep pockets. And society, of course, and of course, they're very politically influential and powerful in the lobbying side of things. But the evidence for the harmful effects of alcohol is substantial, and it continues to accumulate. And just in the last decade or so, the evidence, for example, around the role of alcohol in breast cancer has shown that there's no safe dose. Any consumption of alcohol increases the risk of breast cancer. But of course, the biggest impacts are on violence and injuries, not just motor vehicle injuries, but suicides. It's estimated around 40 to 50% of suicides, and in particular in young people, alcohol is involved. There are significant externalities because often those who suffer from the effects of family violence and sexual violence are children, young people, women, of course. The harms are substantial. And so this is a very, very contested policy area. And New Zealand can and should be doing more in this area. There is still a lot of work to do, and it's really pleasing to see this government has once again picked up the Sale of Liquor Act and is having another look at it to see what more controls could be put in place. It's very contested internationally too, and in one of my years at the World Health Assembly, I chaired a drafting group for a couple of days on trying to get a resolution, agreement and consensus around the harmful use of alcohol and actions to reduce it, both domestically and globally. Well, we were unsuccessful that year, but the next year we came back to it, and a colleague from Iceland, David Gunnarsson, was responsible for the group that year, and they finally did get it across the line. But during the World Health Assembly, he had to come in and report back at the meeting of the whole assembly of all the countries. And this is a quote from him, and he started by saying, "Well, Mr. Chairman, as we all know, alcohol is a tricky liquid." And it's just stuck with me because it's true on so many levels. So in whatever your area of practice is in the future, and it's not just doing a quick social history, do you drink, how much? Ask a couple of questions about this. And in particular, whether there's a really key question which is about asking people about whether they think their drinking is interfering with their life or the drinking of someone else. Alcohol policy, the tricky liquid. Two roads diverged in a woods. Yes, indeed. Now, this, of course, is a quote from the American poet Robert Frost. You may know it. Two roads diverged in a wood, and I took the one less travelled by, and that has made all the difference. So for me, two roads diverged in the woods in about 2009 for me, whether I continue to go down and pursue a career as a technical professional advisor expert, or whether I move more into leadership roles. And I was offered an opportunity. There's nothing like opportunities to kind of help force a decision. I was offered an opportunity to be an acting Deputy Director General in the Ministry of Health. Stephen McKernan was the Director General at that time. It was definitely outside my comfort zone. The old drinking from the fire hose analogy comes to mind. But oh my goodness, it's in these situations where you learn fast. And one of the things I learnt really quickly, so I made my decision that this was the road I was going to travel down. But one of the things that I did was I got a coach. Now, it's a bit like if you're wanting to train to do really well, as a singer, as a sports person, if you want to learn a new language or get better at a new language, having a coach is really good. And again, wherever you get in your career, always think about having someone who you respect, who might just act as someone who you can sit down, have a cup of coffee with once a month or something, and just talk about what's gone well, what's not gone so well. Someone who's perhaps more senior, who can just give you advice and ideas and point out to you things that you could be doing better. Feedback's a gift. Feedback is a gift. So two roads diverged in a wood, and I decided to go down the road less travelled, as it were. And once I'd finished that first stint as an acting Deputy Director General, I then had this amazing opportunity to set up New Zealand's Health Quality Safety Commission. And if you don't know the work of this fantastic guy, Don Berwick, look him up. He established the Institute for Healthcare Improvement in the US. He's regarded as probably one of the global leaders in thinking about quality improvement and safety. And this is a lovely quote from him. We all have two jobs to do every day, and this is all of you as well. First of all, to provide the best possible care and do the best job we can. And second, to work out how we can do it better. So that's always stuck with me, and take that with you because it's a really important thing. You will know, even now, in some of the clinical attachments you have done and in the work you've done, you thought, gosh, why did we do it this way? If only we did this, we could maybe do this a little better or safer and get better outcomes, or more equitably. So he's got many good quotes, and I'm going to share one other one with you, which was when he was here in the early 2000s, we did our first big quality safety conference. And like most conferences, you don't remember much, but I do remember Don Berwick saying this, and it was what he called newspaper boy wisdom. Again, it's stuck with me, and it might be helpful for you. 10% of people are just jerks. This is what newspaper boys observe from going around throwing the newspapers on or selling newspapers on the street. 10% of people are just jerks. For the other 90% of us, we're all jerks 10% of the time. When you've been a jerk, just make sure you're the only one in the room. It's good advice. It's okay to have those off moments, okay? It's okay to kind of look at the wall and, maybe the odd expletive. But just make sure you're the only one in the room. It's okay. But there are people, about 10% of people who are just jerks, and kind of just don't spend time with them, if you can help it. So I got to establish the new Health Quality Safety Commission. It was one of a number of new advisory committees that the Health Minister at the time, Tony Ryle, established. It was a real privilege, and it's still around. There was a lovely renaming ceremony, and as they farewelled their long-serving Chief Executive, Dr. Janice Wilson, just a few months ago. It's now called Te Tāhu Hauora. Supported and led a number of quality improvement initiatives across the system on hand washing, reducing antibiotic resistance, surgical site infection, reducing surgical site infections. It's been really profound. I got offered the job to be the chief executive of that organisation after I'd helped set it up. But I also had another opportunity, and I was really tossing up. But because the other opportunity was to go to Geneva and spend a year at the World Health Organisation. And one of the people I asked for advice from was Dr. Janice Wilson. And she said, "Oh, get out of this place, go like a flash." It wasn't the kicker for me. It wasn't the sort of the straw that made me go, but it was quite ironic that Janice then, who hadn't had any intention to, but then once I wasn't appointed to the role, then applied for the role and got it, and has done an amazing job establishing that organisation. But I did get this real privilege of going to Geneva and spending a year at the World Health Organisation. I had already spent 3 months there in 2009. I'd had a sabbatical, and the way you get to do this is because of the contacts and the relationships you build by going each year. And I've still got close friends that I made even back in the early mid-2000s, and certainly from that year in Geneva. And I had a year on NCD prevention and control. It was a big year. We had a high-level meeting in September at the UN General Assembly in New York. That was quite something to be part of. My role was, I was called the Partnerships Advisor. I was an office of one. So I went from managing a directorate of 100 people as an acting DDG to trying to manage myself. And this was really interesting, relationships with civil society organisations, so particularly the big global ones, the World Heart Federation, the World Cancer Society, World Lung Federation and so on, with the private sector as well, which was quite challenging, and also with academia. One of the things I had to do was help organise a meeting in Moscow Now, when I was at school here down in Wellington in the mid-80s, late 70s, I'm lying, late 70s, early 80s, we were one of 6 schools in the country that taught Russian. So I had done Russian right through to year 13. I don't remember much of it now, but I did get to use it finally when I went to Moscow in 2011. Now, Moscow was an incredibly interesting place to try and organise a conference in. The conference had 90 ministers of health from around the world, and we were all very privileged because we were to be addressed by, actually he was then and still is, the president of Russia. Yes, you know who I'm talking about, Mr. Putin. Well, we all filed into a huge big auditorium, waited. Mr. Putin's security staff came in, checked the place from top to toe, looked under the stage for bombs, did everything, and then we waited and waited for an hour until he had decided it was time to hop in his limo and drive 3 minutes from down the road and come and join the 90 ministers of health and various other assembled dignitaries and grace us with the benefit of his presence. And while we were standing there waiting, I turned to the conference organiser, who was Russian, who I'd worked with, Elena, and I said to her, "Does he do this often?" And that's what she said. He kept the Queen of England waiting for 10 minutes. It's a power play, isn't it? It's a power thing. And this happens to some leaders, you know, and some, they seem to be male more than female, where it sort of goes to their head, you know, and of course it's always about the power. So remember this, the only appropriate use of power is to empower others. The only appropriate use of power is to empower others. And you can see when that doesn't happen. The quote down the bottom, so the quote from the top is from the conference organiser in Moscow. The quote from the bottom is, of course, from The Clash. Should I stay or should I go? Great song. Well, we had a marvellous year as a family in Geneva, and I was offered a role to stay there, but we decided we would return to New Zealand, partly for family reasons, but also I just felt, you know, this was where I wanted to be and to continue pursuing my career. So back we came, and I acted for another 8 months in the role that I had been acting in. I'd spent a year acting in it before I left. Then I applied for it, and I missed out. Didn't feel very good at the time, I can tell you. I felt pretty gutted, and it was a role I'd always wanted. I'd acted in it for nearly 2 years. You know, I knew it well, or my team expected me to get it, and I didn't get it. I was told on a Friday by the then Director General of Health, Kevin Woods, and he said, "I've got some other thoughts about what you can do. Don't do anything precipitous." I wasn't planning to do anything precipitous, but I said, "It's okay, give me the weekend just to you know, work it through, and I'll be here on Monday morning." So over the weekend, I rang all my executive team members up, told them one by one. They were kind of shocked and disappointed as well. And 2 days later, I got a phone call from a chief executive of a DHB who said, "Would you like a cup of coffee?" And a new pathway opened up for me, and I ended up working out in the district health boards. And in retrospect, you know, you'll have these disappointments in your career, and you may already have had them in life, but there's always another pathway that opens up. And for me, that was actually the best thing that had happened in my career. No, I didn't feel like it at the time, I can tell you. But it was the best thing because I got this amazing opportunity to work out in the district health boards. And then 3 years later, to apply for and be appointed as the chief executive at Hutt Valley District Health Board, which is where I lived. And I had this glorious time working there, cycling up the river, the Hutt River, Te Awa Kairangi, every morning up to the hospital, working with fantastic people, and then cycling home at the end of the day, feeling even more energised than when I started the day. And just that opportunity to work closely with clinicians and great managers and patients and their whānau, Māori Pacific providers, all our providers in the communities, GPs, pharmacists, mental health providers. It was just such a privilege. And probably, you know, except of course being DG and the job I'm in now, your best job, by the way, should always be the job you're in now, because if it's not, you're in the wrong job, isn't it? So, but I love being a District Health Board Chief Executive. And I learnt very quickly, so what do I do now? And this is common. I've talked to other Chief Executives. When you get your very first Chief Executive role, you arrive in this office and, there's been a welcome and you sit down behind the desk and suddenly it's you sitting there by yourself. And the first thing that comes through your mind is, so what do I do now? I'm the boss here. It's all dependent on me. Well, it's not all dependent on you. It's not for the faint-hearted being a chief executive, but my goodness me, it's rewarding. And I very quickly learnt what I did now because I had a senior clinician, Chris Adams, he's a plastic surgeon at the Hutt Valley, great guy, and we knew each other well. And he came in and he said, look, because the DHB had been through a bit of a rough patch, the chief executive had left because he had got offside with the chair. And he said, for goodness sake, can you just make decisions? We've got all these things sitting there waiting. He said, we don't mind if it's no. He said, well, we will mind. We'll be grumpy. But at least then we know the decision's been made and we can move on to the next thing. And that's the thing, because no decision is a decision. And there's nothing worse for people when you're in a leadership role or in a clinical situation is not to make a decision. And you're never going to have complete information. But I worked out that my role was to make decisions. And I enjoyed doing that with people. It was great. But the really rewarding thing is you set the tone and culture of the organisation and people are watching you the whole time. And through what you say and what you do, you can have an enormous influence on an organisation. And I'm really proud of what we managed to do in the Hutt with sort of creating expectations around values and behaviours and then holding each other to account to live according to those values. It's really important. Remember, people won't remember what you said or did. They'll remember how you made them feel. And how they feel is how you behave towards them. I should have read the fine print in my contract for DG. It must have said somewhere there will be a 1 in 100-year pandemic. But I didn't see that, and so I took on this role. I applied for Director General of Health, got the role, started in June 2018. It's a pretty complex leadership role even when there's not a pandemic. So you're the chief executive of a pretty big organisation. You're effectively the leader of the health system, and in those days trying to wrangle 20 DHB chief executives and all sorts of other things was quite a big gig. You're the government's principal advisors on all health matters, and you're part of this broader public service leadership team along with chief executives of all those other government departments. You provide leadership across the public sector. So this is a 24/7 job, kind of even when you're on holiday. I came in mid-2018. I had the really good fortune of, now I look in retrospect, of about 6 months to build a strong team, because 2019 came and look what started to happen. I've already talked about that measles outbreak here in Auckland, which took a lot of work to get under control, but in March that year we had the terrible terrorist attack down in Christchurch. It's the first time I met the former Prime Minister. Jacinda Ardern was on that day and then that weekend following, because our amazing colleagues at Christchurch Hospital had saved the lives of many people who'd been shot by that terrorist. And then we had the Whakaari White Island eruption later that year, which I was involved in fronting the media on. But of course what we didn't know was March 2020. We would have a pandemic declared, and of course later that month this country went into a lockdown, and I don't need to say too much more about that because Harrison's already said we did a good job. So that's fine. There was a little bit of work in between, but it's the outcomes that matter. But of course also governments in their wisdom love to do things like fully restructure health systems, and so there was also a full health system restructure that happened that was designed and put into place while we were in the middle of a pandemic, and I'm sort of pleased to have been able to step back, at least for now, from that and work here at the university and do the work internationally and just observe and support my colleagues who are still leading what is, of course, a really challenging time in a challenging sector, not unique to New Zealand, not unique at all to New Zealand. All the issues we are facing here, particularly the health workforce ones, are absolutely the same in every other country. So don't think they're unique to New Zealand. But what of course we did show in New Zealand is that we are uniquely placed to solve and respond really well to even the toughest problems. So this is what Harrison was basing his assessment on. Excess mortality. Now, you may have learnt now that people quite appreciate being alive. It's quite a good gig. As the comedian Jimmy Carr said recently when he was doing his tour and he was here in New Zealand, he had a gag that was something like, yes, so there are lots of people now, or some people now, who are saying we overreacted to COVID. A lot of people who are still alive saying that we overreacted to COVID. Imagine if we could poll the dead. Well, fortunately in this country, because of the actions we took, and because of the actions of New Zealanders, look, there's New Zealand down the bottom. After 3 years of a pandemic, we still had negative excess mortality. Less people had died in New Zealand in those 3 years than was predicted based on prior trends. And look what happened in other jurisdictions and countries. I'm saying jurisdictions because we know Taiwan is a jurisdiction, not a country. But even Taiwan, which, as we know, Michael Baker was promoting as the exemplar, the gold standard response, had more excess deaths from COVID than New Zealand did, let alone the Norway, Sweden, Germany, United Kingdom, United States, or South Africa, perhaps as a representative of one of those middle-income countries. Or to put it another way, the extra people in New Zealand that would have died if our experience had been the same as those countries. The former president of the USA got impeached rightly because the Capitol was invaded in Washington, DC on the 6th of January a couple of years ago. And he's been found to have helped incite that. Several people died. Several 100,000 people died unnecessarily in the USA, despite it being the best resourced country in the world, because of the failure, really, of leadership of their COVID response. More Americans died unnecessary or preventable deaths from COVID than died in every war in the 20th century. Americans, I'm talking about First World War, Second World War, Korean, Vietnam, Iraq War. That's the travesty. And you would think that people had forgotten about it. Collective amnesia. Well, I'm really proud that in New Zealand we did our very best because we were playing it, we were learning it forward, weren't we? There was no rule book. Learning it forward is public service speak for making it up as we go along. But the great thing is we protected our population. We minimised to as great an extent as possible the impact that that pandemic would have had on our most vulnerable communities. And here's just one figure, and you will remember this. If you were under 60 and had a pre-existing condition, you were 78 more times likely to die from COVID than if you didn't have a pre-existing condition. Pre-existing conditions were the biggest driver of the higher burden of deaths amongst Māori and Pacific. So for all of you, one of the most important things you can do to prepare for the next pandemic is make sure if you're involved in the prevention and care of chronic diseases, particularly for Māori and Pacific, do your job really well and keep working out how to do it better every day. Oh, the places you'll go. Of course, that's a quote from Dr. Seuss, and I'll finish with that. Okay, this is kind of life advice, people. We're through all the population health stuff, so you can, we're there. Last slide. Develop and nurture strong relationships. You might have heard me talk about Don Matheson, one of my bosses earlier on. He said this to me early in my career. In any interaction with someone, spend 80% of your effort and time focusing on the relationship and just the other 20% on the transaction you're trying to do. This is what will be the most important thing for you to do your job well in future. Take any opportunities, particularly the ones that put outside your comfort zone. Any experience you can gain, not just ones that enhance your technical expertise, but just your understanding of people and of life and of systems and of the way the world works. Take advantage of our unique history, culture, and the advantages we have over other countries, and be comfortable in walking across. Says Bridget, I don't know why it says Bridget. It's spell corrected. It's the bridge between your world and Te Ao Māori. And don't just expect Māori to walk back across the bridge to our world or your world. Be comfortable walking across. The reception is great on the other side. Okay, and this is something that is unique to our country and such a privilege for us all. And understanding Te Ao Māori, you don't need to know everything about it or necessarily agree with everything about other people's worlds, but understanding it will enhance your ability to be an effective clinician and person and health professional in Aotearoa, New Zealand. Of course, I had to put this in for Boyd, but use epidemiology and public health to save a lot of lives and reduce inequities. I've shown you a couple of examples of where public health action has saved thousands, if not hundreds of thousands of lives over decades. And use it in your work. As Boyd said, whatever work you do, population health approaches and epidemiology will be fundamental to you being effective. Lead yourself, know your moral compass and use it, and act from your values, your behaviours. We judge ourselves by our intentions, others judge us by our behaviours. And enjoy your work. This is really important. Okay, I've got a literary quote here, so I better use it. It's from Shakespeare. Of course, The Tempest, Act 3, Scene 1. This is Ferdinand speaking. He's fallen in love with Miranda. Of course, this is Shakespeare, so of course he's fallen in love. And he's actually a prince, but they've all landed, there was a shipwreck, they've landed on an island, they don't know who each other is, and he's been relegated to carrying the firewood. So he's carrying a log, and this is what he says. This, my mean task, would be as heavy to me as odious. But the mistress which I serve, that's Miranda, quickens what's dead and makes my labours pleasure. Makes my labours pleasures. There's another lovely quote here. This is from the Nobel Prize-winning Bengali polymath, Rabindranath Tagore, and he wrote this, and I love this. I slept and I dreamt that life was joy. I awoke and I saw that life was service. I slept and dreamt that life was joy. I awoke and saw that life was service. I worked and behold, service was joy. So, let me remind you finally, just before I get to that, this is the advice, my advice is very Gen X, okay, so here's some Gen Y advice from my daughter, who's an engineer, worked for 3 years postgrad, just gone to the UK. This is her advice, probably most important. Be reliable, be teachable, be a team player, get noticed by doing more than your job description and show initiative. It's probably as good a summary as anything. That was her advice for, how to get on in your first jobs. But just remember this, humans singularly have the ability both to imagine a better future and to make it happen, So don't stop dreaming. Remember, Martin Luther King didn't say, I have an idea, or I have some new evidence. He said, I have a dream. So keep imagining that better future and do something about it. Things have never been better than they are, and they can get better. And the final word, of course, goes to Dr. Seuss from All the Places You'll Go. You have brains in your head. You have feet in your shoes. You can steer yourself in any direction you choose. You're on your own, and you know what you know, and you are the one who'll decide where to go. But make sure you think about population health. Kia ora. Now it's time for questions. We're not going to do this like the media stand-ups where they just shout questions at me. So, if you have got a question, and there might be some online, I think Anna will be curating those, just do put your hand up. If someone's already asked your question, just feel free to ask the same question. I'm quite used to it, all right?
Kia ora, Ashley. Thank you so much. Let me just give you some chocolates before I forget to take them with me from a nutrition expert, or so-called. Kia ora. Okay, thanks very much for that, Ashley. And I'm just going to, as promised, pick somebody randomly just to thank you and kick off the first question. So I'm just going to see, is Vanessa Tan in the audience? Where's Vanessa? There, Vanessa, okay. Vanessa needs what happened to the other microphone? Oh, here we are. Vanessa, I'll give you this. Can you just, I'll take this one. Can you just thank Ashley and ask him the first question?
You can ask me anything you like. While you're thinking of your intelligent question, I can tell you probably the most common question I get asked is, so how did you choose between Tova and Jessica every day? Phone a friend if you like, or just ask someone next to you.
Okay, let's go over here. Thanks.
Cool. Yeah, thank you very much for the talk. I found it really interesting. Nice to have kind of a window inside what I think is sort of quite an opaque world for a lot of us. My question sort of relates back to your time dealing with sort of drug classification and so on. What do you think of the continued use of a prohibition model for drug control in New Zealand? And I think we have a particularly inelastic mechanism for it. With, just as an example for people, the Misuse of Drugs Act, with its sort of separate levels of classifications, no drug has ever been moved from a higher level down to a lower level. And I'm just sort of wondering what your thoughts are generally, but also with a particular New Zealand circumstance.
So a couple of comments here. First of all, and I think you've made a good point here. The Misuse of Drugs Act is kind of no longer fit for purpose in the sense that the approach that is taken and has been for many years, including when I was more involved in it, is a harm reduction approach. And yet the classification process and the sort of the prohibition type approach is not very congruent with that harm reduction approach. So yes, the Misuse of Drugs Act needs to be updated. It needs a much more, it needs a much stronger harm reduction focus, and New Zealand's done quite well in some of these initiatives like needle exchange schemes and so on. And just a few years ago, there was an agreement with the police that was under the previous government where the police wouldn't prosecute, or wouldn't prosecute people for possession or use of most substances, but instead treat it as a health issue. So that's a good direction. So saying, this is the kicker here. The supply of substances, including illicit substances, but also licit ones, is a big driver of their use. Tobacco is a great example. So you have to have both supply side measures and demand side measures. And alcohol is another fantastic one. Supply side measures are things like having minimum prices, reducing the visibility of alcohol sales outlet, constraining the number of outlets. There's very good evidence that shows the more outlets there are in a community, the more alcohol-related harm there is. So the question that still hasn't, in my mind, been addressed is if you don't have a sort of a prohibition-based approach, but you have a regulated market for these substances, how do you stop really big multinationals from getting hold of them and creating a market out of nothing? And I'll give you an example, because look what's happened with vaping, okay? Vaping has got a really important role to play in helping smokers quit. However, I started to get worried as soon as the tobacco companies started buying up all the vaping companies, because they, A, have no ethics, we know that. They just are completely unethical. But B, they are incredibly good at mobilising billions of dollars through marketing and advertising to generate a market and to get their products sold for the sole purpose of making money. So I think what I haven't seen yet is alternative ways to create a market so on the supply side that is going to be safe and help really regulate and control supply. So there are a couple of thoughts there.
Kia ora, thanks for that. Any questions from the regions, please just send them through. Okay, any other questions for, yeah. What the hell happened to Vanessa? Come on. Send the microphone, just put up your hands at the moment, just send the microphone along there, please, so that we can...
Boyd, we've got one, yeah.
Okay, let's just take this one and then we'll take one from the regions, yep.
Kia ora. Thank you for being a caring leader and for your talk today. My question is, could you please tell us about one of the moments you crossed the bridge to Te Ao Māori and how this made you feel?
Yeah, well, the key thing about it is trying to kind of cross the bridge regularly, like every day, thinking about, and that may be kind of both through specific interactions, but also it can be metaphorically as well. Think about what do I need to do as I read this, or what am I going to read to help me understand Te Ao Māori a bit better. One of the things that you will notice I did right from day one, and I never thought about it with the stand-ups, was the greeting I would start with, and then two things, and I'm speaking actually at a hui next week that the Māori Language Commission is organising about this, is to be assiduous in my pronunciation of Māori words and place names in the media conferences, even when it might have been said to me as the classic Kiwi sort of version of a place name, and to just throw as many te reo words in that I was comfortable with in those media stand-ups, and some of them have kind of caught on. People talk about around the motu now, and mahi, and I think this is a part of the journey that New Zealand is going through, is just kind of actually embracing this language. Now, I got very, very little negative feedback about that. I got the odd predictable letter about, why do you always say Aotearoa New Zealand? It's New Zealand. Right, okay. All right, thank you very much. And one fellow wrote me a very interesting letter saying that he was fine with use of Māori, but the problem was the kind of cross-pollination, and that we should keep English, separate and not throw Māori words in there, because that actually undermined Māori as well. I wrote back disagreeing agreeably, and included in my letter a number of words that we use on a daily basis that are borrowed from other languages, including Latin, which is a dead language, and we use them, of course, in our everyday work. So I'm really excited about the increased use of te reo in our everyday lives, and I see that as a huge advantage for us all. And I'm just pleased that I had an opportunity to be part of helping normalise that through the role I played.
Okay, thanks. Let's just take one question from the region. Can you pass that microphone back to Vanessa? Because she's still going to find her voice to thank Ashley at the end. Right.
Okay, I'm not sure which region this is from, but it's asked, regarding the regulation of alcohol, have the events following the US prohibition of alcohol in the early 20th century influenced potential policies being considered?
No, I don't think so. Yes, and it goes a little bit to the question earlier on about prohibition. And the problem with prohibition is you end up with an illicit market anyway, and that has its own attendant harms. But we often underestimate the harms associated with full-scale marketing and influence on our social fabric that comes from many of these substances if you have a regulated market. But there are many, many opportunities to regulate the sale of alcohol a lot better than what it is here in New Zealand. And again, this is not just an issue for New Zealand. What I should say, though, is, I didn't show data about alcohol consumption and binge drinking amongst younger people in New Zealand, but it's actually declined over the last decade and a half in New Zealand, so that's a good thing. Binge drinking is probably as much, if not more, of a problem in people in my demographic. In other words, the 40 to 60 age group. I won't tell you which end of that demographic, but if you were listening earlier on, you'll be able to work it out. So that's what good policy and regulation and law and good governance does. Is it constantly reviews and puts in place things that improve the well-being of individuals. And where there are gaps, you show political courage and step on there.
Well, kia ora, thanks, Ashley. And just as you're been going through your talk, it just reminds me a little bit of the satisfaction or what you get out of public health from population, dealing in population health, as opposed to a clinical role where you see your patient and you help them and they come back and they say thank you very much, and you can see the improvements. Hopefully, they might even give you a bottle of wine at Christmas or something like that. But the feedback is immediate. Whereas some of those things that you've been involved on, you showed one or two data slides, and like the smoking coming down, you have have been a cog in something and your satisfaction comes from seeing a graph over 20 years. That's a different kind of level of job satisfaction for knowing whether you're doing any good or not, isn't it? So that is a bit of a challenge, but I think that difference between that, we need both kinds of satisfaction with the people we work with and the leadership, but also for us at the population level, it does actually come in some of the graphs, doesn't it?
Yeah, that's a good point, Boyd. And your feedback accumulates over time in public health. That's the great thing. And the point you made, which is a really good one, is it's the same in clinical medicine. It's never about individuals. It's about what you achieve collectively. Leadership is an invitation to collective action. It's not about the person up the front shouting commands. And as you said, in tobacco control, that is the work of many, many, many good people who have been tenacious and kept going, even at times when it was quite dispiriting. And even at times, and Boyd, you were subjected to this, when you're subjected to, vilification by people who've got a platform. Boyd, like me, has probably been called a health Nazi.
Oh, God.
Public health Nazi, trother, feeding at the trough of public health jihadist, been called all those things. Yep, too bad. We're here still, and look, we've made a real difference. So well done to you.
All right, well, thank you very much indeed. Now, Vanessa's just going to say a few words. Feel free to throw in some te reo if you want, Vanessa. But over to you to thank Ashley.
I just want to say thank you for being here, sharing your experience and time. And it's really nice to see you in person after seeing you on the TV. Thank you so much.
All right, everyone, we're back in half an hour at 11 o'clock for the next part of the symposium. Thanks very much.
Thank you. Of course, yes.
I'm from Singapore, so I'm really a fan of you.
we'll have questions for her, and then I'll get you and Jin. In fact,
my slider, because it's my little site of resistance. Do you mind if I leave that up, Boyd? That's just my site of resistance.
that's all right.
In our beloved medical school. Where everything's named after some Everybody there, yeah.
I read an article somewhere where a woman went through all of female sexual organs and parts that are all named after old dead white men.
God. Wow.
Can't even remember
Not
most of it, you know.
I'll take that for sure. That would be an interesting talk, actually. That would be a very interesting talk. Right, I'll get rid of this. I've got all my accoutrements. I'm just going to speak into this. Yeah. I've got quite a loud voice.
Okay, come on in, guys. Okay, guys, kia ora. Welcome back. Hope everybody's online on the YouTube. And just a reminder to put questions in the YouTube chat for those people in the regions. So welcome back. We're now going to have the second part of the symposium, which is panel presentations and discussions. And we're going to be hearing from practicing clinicians and hear about how they join up their clinical practice and the public health. They're both three magnificent female doctors, women who are clinicians who operate and make a real difference in the clinical world, in the public health world. Henima unfortunately has to leave early, so we'll get her to do her presentation first, and then we'll have Q&A for her, and then we'll have Jin and Penny follow, and then we'll have discussions with the two of them together as a sort of a slightly smaller panel. Same thing, we're going to get a person who's pre-designated to introduce Henima and then Jin and then Penny. But I will ask another random person in the audience to ask the first intelligent question. So Vanessa's set the bar and we'll see how we go. All right, now we have Nairi Waipori. Nairi here to come and introduce Henima. Thanks very much.
Tēnā koutou katoa, ko taku honoro ki whakamohia atu ki a koutou i tō tātou kai kōrero tuarua, me mātua mihi au ki a tā Ashley Bloomfield, e mihi ana ki aia mō tāna kōrero. Ka mihi hoki ki a tātou katoa, e tai mai nei ki te tautoko i te kaupapa o tēnei wiki i Population Health Intensive, e mihi ana tēnā koutou, tēnā koutou, tēnā koutou katoa. Morena everyone, it is my honour today to introduce you to our second speaker. But first, thank you to Sir Ashley Bloomfield for his kōrero, and to you all for coming in today and zooming in for Population Health Intensive this week. Our next speaker is a prominent figure in the field of mental health here in Aotearoa and abroad. After graduating from this fine establishment, she went on to work as a youth forensic psychiatrist and now specialises in child traumatic brain injury. She completed her PhD with a focus on the development of a tikanga Māori approach to working with Māori children and their whānau dealing with traumatic brain injury. And she has embedded this tikanga into her practice. She is highly regarded within the medical community and this was recognised in 2019 when she received a New Zealand Order of Merit for her services to psychiatry and Māori. She is considered a rangatira within the Māori community, and she is listed as one of our top 100 leaders for her mahi with whānau Māori. Psychiatry aside, she is also a fierce advocate for te reo Māori. She has published 2 books and co-authored another, and she didn't enter medicine straight out of high school like the rest of us, and I'm probably the only one here who remembers watching 345 Live. E te rangatira, tēnā koe. E mihi ana ki a koe, mau I haere mai ki te toha au kōrero ki a mātou I te ata nei. Nau mai haere mai. Please join me in welcoming Dr. Henny Moore-Elder.
Te whare tū nei au e karanga mai, te marae tā koto nei karanga. E te iwi he pai nei, tēnā rā kōtou katoa. Kui mā, koro mā, tēnā kōrua. Rau rangatira mā, nā rangatira moa popo tēnā kōtou. Nā kai whakahaere o tēnei wiki, tēnā kōtou hoki. E noho anau I te roro o tōku whare. Ko te reo mihi tērā. Whakarongorua rā ku taringa ki te tai o pārengarenga. E āki ana I te taha o tō mātou waka ko kurahau pō tērā. Ka huri whakateraki atu ki Murimotu. I hoki maharau ki tūmata hina me tana mahi e ora ai te iwi. E ai ki aia, te kuaka marangaranga, ko tahi manu I tau ki te tahuna, tau atu, tau atu, tau atu. Anei te tahi kuaka e mihi ana ki a koutou katoa. Right. Kia ora. Wow, it feels quite weird to be back here, I have to say. I was just joking, sort of joking, to Boyd. Like, all of these places in our medical school are named after old white men. Doesn't really represent who we are. I think I might have touched something. There we go. We're back. Hang on, here we go. It's very sensitive up here. And pardon me, I've got a bit of a cold, rat negative, not COVID, but I'm just going to sip on my tea to keep my throat okay. So, it's Ariroa in the Okoro, or the Maramataka Māori, and that's the name of our Māori moon, Hina, that she gives us today. So it's actually very fitting. It's a time of the power of being direct, the power of making eye contact, and we're lucky to have the technology to have some colleagues in other parts of the country. Ngā mihi nui ki a koutou I te ipurangi. So this is a great time to hold wānanga, and we're also coming up to the period of matariki. So I'd be interested for you to reflect on that over the course of your week and how matariki might actually represent a public health initiative, even though it hasn't necessarily been set up for that. So this is my site of resistance today. This is a picture of our grandmother's mother, Henny Murray. Now, like many of you, I grew up with this picture in our home since I can remember, since I was a really little girl. And this woman died in March 1919. You can probably feel where I'm going. She died in what was called the Spanish flu, or the Great Flu. And she, at the time, she had a 6-month-old baby and 7 other kids, one of whom was our grandmother. So she is one of the most powerful faces of public health for me, for us, for many of us in Te Hiku o Teka, the far north. So her death and many of the other deaths of our whanaunga in 1918 and 1919 led to all sorts of changes in our communities. And you can just begin to imagine the ripple effect of our parents, of our children dying in ways that we have witnessed in COVID 100 or so years ago. And so these have been important lessons for us as doctors, particularly perhaps those of us descended from people like Kui Henny, who died at that time. We are their mokopuna, and I've certainly come to feel a new sense of responsibility and accountability to future generations to pass on what we've learned. So we've all had various periods of adjustment and readjustment because of COVID, and we heard from Dr. Sir Ashley Bloomfield about some of his really personal experiences around that, which impacted on all of us. So throughout that period, I'm going to talk a bit about some of these experiences. I continue to work with patients and their whānau in various services. I was part of discussions with colleagues, online panels, other media about practical approaches to help parents, to help our whānau begin to talk about safety, about what the numbers mean. So I've only got one slide. You've had lots of numbers on slides from Sir Ashley. So I thought we could have a little pause from the numbers game in public health, because public health is not all about the numbers, although they are very important. So yeah, helping our whānau, our communities to unravel and make meaning of these numbers has been a key part of what I, alongside many other people, have done in the last 3+ years. How to be a whānau in a pandemic, how to parent, how to manage stress, how to try to stay alive, to reduce the very risk of illness, and you heard about comorbidities radically increasing the risk of illness and death. That's the reality for our Māori and Pacifica whānau. We all have comorbidities, more or less, right? That's our reality. And of course, this whole situation very quickly became polarised and complicated by mis- and disinformation, especially for Māori. And so I think that's another layer that I'd like you to keep thinking about in your deliberations over the week about the information that comes through as public health information, and is it all correct? And how do you, as the mouthpiece of some of that information, help others to really get to grips with what that means? So, one of the big lessons for all of us from COVID has been that in modern medicine, no matter where you end up practicing, having a public health mindset is critical. And what do I mean by that? Well, one of the fundamentals is for all of us to remember and keep refreshed in our minds and our practice that conventional health services are not the sole solution to illness and disease. So I think one of the lessons that we might get from the medical school sausage factory machine is that we're going to end up in health services, and health services are the key. And we're going to be cogs in that great machine, and we're going to help people and cure illnesses and work with people in clinics, right? That's a big story that we get influenced by. But actually, focusing solely on individual patients and their immediate families is not all that we need to do. That one-on-one way of working is not going to do the job we need to do as doctors as health needs continue to evolve. So let's have a look at that critically. So for one thing, a key part of what we do is we take evidence from research on groups of people and we draw some inference that's meaningful for the people that are in front of us, that we're looking at, right? And we also recognise that there's other people in the room that might not be physically there but are being influenced to the people we see, right? So the people in the room that we see are not the only people in the room. We also recognise that much of the evidence base we use is conducted with rarefied groups with only one condition or exposure, whereas in real life, well, life is messy and complicated. So we have to try to translate that rarefied research often into the messy spaces where we work as doctors. So one of the central findings from all the evidence shows that population health is the key determinant of health and wellbeing. You're going to hear this like a broken record all week. And there's a reason for that. You know, it's just such a critical piece of the puzzle. Where you live has a greater determination on your health and your life expectancy than your biology. Yeah? So it's been famously said by many people, variations of this, the area code is more important than your genetic code. And that might not be the sexy message that you want to hear. Coming from someone who worked in Brain Research New Zealand here for nearly 6 years, and I've been involved with lots of research around the brain injury, you've heard as part of my backstory, neurodegenerative diseases, but actually what we know about neurodegenerative diseases is they are lifestyle diseases like diabetes. So the sexy story of the brain and how we can do fancy research with the brain actually doesn't tell the whole truth of the matter. Population health, groups of people's health needs must always be part of our formulation and part of our risk assessment. So yep, I'm a psychiatrist, I work in youth forensics as well, so we're constantly thinking about the interplay of different kinds of risks in people's lives. And I think the population health perspective gives another layer of risk assessment that's really, really important for all of us. So when I was a student, I was thinking, what were some of the really key experiences I had as a student that made me think about population health? So one was, when I was a student, I did a cardiology run at the old Green Lane Hospital. One ward was full of Māori and Pacific young adults who had rheumatic heart disease. And they were waiting for valve surgery, most of them, or some other kind of cardiac surgery. And we had several German students who had come because they'd never seen rheumatic heart disease before. And the only place that you could go and see that was India. Right, I was very disturbed by that. This was the 90s. And what's changed? Well, really nothing. In fact, if anything, the situation is worse. There's some research that came out last year that found that Pacifica children from 5 to 14, Pacifica children are 80 times, that's right, 80 times more likely to get acute rheumatic disease, rheumatic fever, compared to Māori children who get 40 times compared to everybody else, right? So there's this huge disparity. And why is that? Well, that's because Māori and Pacific Island children are much more likely to live in poverty. And why is that? Well, it's not their choice and it's not their parents' choice. It's not because their parents have done bad things or are neglecting them. It's because of years of intergenerational racism in education, healthcare and housing. And it's because of government-induced poverty. Something else to consider over the week. You're probably going to hear a lot about the impact of poverty. So there are lots of other examples that show how public health mindset helps us to understand the bigger picture and recognise our roles in advocating for effective change. Our role is not to simply accept these issues as the status quo and risk becoming part of systems perpetuating these inequalities. I spent a year, just keep an eye on the time, I spent a year as a senior reg and consult liaison psychiatry at Starship. And that was in 2004, seeing lots of Māori kids with TBI, with traumatic brain injuries, with brain tumours, with strokes. And I learned a lot about the epidemiology of TBI and how overrepresented we are. And we've got really good data from the Christchurch Health and Development Study and the Dunedin Study. So we've got really good local data that is available to all of you and will be really meaningful to all of you because it comes from here. So I also reflected on the kōrero that I'd grown up with from our wahine tupuna, like he tapu te upoko. The head is sacred. But I never heard anything about that when I was at med school. I never heard anything about that when I was at Starship. And so I was like, why is this cultural silence? Why is there an absence of really important cultural information that can help us springboard into other ways of doing research and helping our own people with these kinds of problems? So I might skip over some of the things, but essentially another thing I wanted to encourage you to do is think about further research. When you're a clinician, think about the things that trouble you, that you notice, that you want to change, and think about doing a PhD, because clinically applied research is incredibly important. You know, and I can hand on heart say that I did my little PhD and postdoc, and now that material, those resources, it's being used in rehabilitation. We're using it in the inpatient unit at Starship where I work now. So these are things that you can all uniquely contribute as practicing clinicians with a population health mindset about the bigger picture and making things better, to reiterate what Sir Ashley said. I wanted to just touch on a couple of other things about COVID. So it's normal for us as Māori to be deeply questioning of any kind of government-imposed mandate. We've all grown up with our personal experiences and our collective experiences of racism, and we know how racism impacts on all of us, on our patients, on our whānau, on our tangata whaiora. There's a wealth of really good public health research about racism, and I encourage you to read it and think about it. So I'll never forget arriving at the National Library Theatre in Wellington, 30th of July 2021. I was an invited speaker for the COVID team's Mental Health Day, and I was really honoured to be there. And before me, one of my colleagues from the Ministry of Health, Māori colleague, was speaking about the vaccine rollout. And she was saying, this is a racist rollout. And I thought, that's bloody right too. That's right. And some of the people up the back were calling out, we tried to tell them. We tried to tell them. They tried to tell the politicians. And just so we're clear, why was it a racist rollout? Because less than 5% of us Māori are over the age of 65, and about 20% of non-Māori are. The largest group of Māori are under 4. So what that vaccine rollout meant was that we, as a Māori community, were going to be exposed to the virus for much, much longer than other people, in a way that really matters to us, right? Because we're younger. So that was a really salutary experience. And what that told me was, wow, public health, population-based evidence doesn't always make it through the political triaging of priorities to implementation. So evidence is highly politicised, and how it's implemented is highly politicised. And you will see this throughout your career. Because of COVID, as doctors, we're having to make decisions when we're really stressed, in a way that we've never experienced before. The last 4 years has been a roller coaster ride. We're tired, patience is harder to find, we've struggled to maintain and regain any sense of routine. Our own baseline levels of anxiety mean that the threshold for being burned out has changed. It's much more sensitive. Your training has been disrupted. You all have first-hand lived experience of how many layers of COVID have impacted on you and your whānau directly, from a huge public health crisis and what that means to you. So I was at Starship in the inpatient unit. We call it Haumaru Orite. That's the adolescent unit and the mother-baby unit during the first lockdown. I had to go into PPE to see psychotic teenagers. How horrific was that? I could say they were already petrified, terrified, and then for us to be dressed like that, no matter what we tried to do, there was no way to make that easy, right? That was horrible. Then I helped out, we had a massive waiting list for people to be seen at the Kari Centre, which is the local CAM service. That was a nightmare because whānau was so disrupted and so anxious that the level of suicidality was off the scale. So we all bore witness to this new level of community desperation and suffering. So COVID's also reminded us of our global connections. I'm sure many of you had whānau who were overseas, who were very sick, or who died from COVID in the last 4 years, and you couldn't go and be there. We had to stop having tangihanga. We had to stop having hongi. We had to bring back some of the practices that we had in 1918 and 1919, you know, these sorts of things that they did back then. So we're living with the changing face of COVID. We're learning it's much more than an infectious disease pandemic. It's a syndemic. It's exposed all the problems that we already had, and it's thrown petrol on the fire, right? COVID kills the most vulnerable. So maybe I should start to wrap up here. I think, you know, looking at the pictures from the Great Flu, we can learn from that. They wore masks back then. I don't know if any of you have seen the pictures. There's some bird-like masks, but only for people who had the money to access them. And we know that here in Aotearoa, the local councils were in charge of the health of each area. And there are accounts in many Māori communities where the police held Māori back from going to the hospital. It's actually really shocking, makes me really upset even saying those words today. But those are the realities. Māori were treated different then, and we were treated differently again. We then had to get our heads around the vaccine thing, and we saw how the disinformation, misinformation, actors in that sphere on social media in particular whipped people up, some people into a frenzy. So, as a child and adolescent psychiatrist, I think about intergenerational whānau. I think about communities and the prevention of mental illness and the protection of well-being. So, a lot of what I do is to try to bring the lessons from the severe end of mental illness, where I spend a lot of my time in the Starship and in youth forensic services writing reports about really terrible things that have happened, and bring those lessons into prevention and public health. So we have a huge responsibility, don't we, as people who choose to be doctors, who choose this very difficult path. I'm sure you already know, this ain't for the faint-hearted, right? But we are, stronger together. We are the embodiment of our whakapapa. Ahako he Māori, Māori mai, Pākehā mai. We all have whakapapa. We all have people who've been affected in pandemics and epidemics around the world, without doubt. That could be something to share in terms of stories. Our first job, I think, is to stay open-minded and bring all of our critical analysis to serve the needs of people's health and well-being. That's our purpose. So for me, it's about holding fast to my roles as a mokopuna of this wonderful wahine, as an ancestor of the future, as a doctor, as a person who needs to be ready to use my skills and supports to help others with this public health mindset. So with the tools of public health, I'm much better equipped to deliver that to both individuals and to communities. So he whakakapi māku, he whakatau aki tēnei mai kēngi tāwhiao, ki te kotahi te kākaho ka whati, ki te kapuia e kore e whati. If we work alone, we can be broken. But when we work together, we're invincible. Kia ora.
Kia ora, thanks so much. Whoops, that's not even on. For some reason it's not going to be. Give me one of those.
I have to project your voice.
I have to project my voice, but the thing is I'm projecting it out to...
the other centres, no?
To the other centres. Hello, hello, hello. Okay. Thanks so much for that, Henimoa, and bringing that perspective, this sort of the racist rollout of the vaccination process. That was pretty evident, but I think it's just a wider reflection of other things that happen in our system. Now I'm going to choose somebody here. Who have we got? Rory Burnell. Is Rory here? Rory, okay.
Kōrero mai, Rory. Kōrero mai. Whātai mai.
If you could ask the first intelligent question, Rory.
We're just sitting at home having a kōrero. Rory, whātai mai.
Kia ora. So my question was, from your work in traumatic brain injury research, was there any particular takeaway that you took from that in regards to, helping prevent that from occurring in particular marginalised communities?
Kia ora, Rory. That's a very good question. He pātai rangatira. So, for me, I always come back to the basics. What are the big things that people can do? What I learned about was that our culture has amazing resources, and a lot of our Māori don't have access to those cultural resources. So I think one of the big ticket items that I learned was when our whānau recognise and are offered an opportunity to recognise how powerful our cultural resources are, that's the game changer. Because then that doesn't only affect taking care of the head, it affects taking care of all of the things that affect the oranga of a whānau. One of the central ideas that I identified in my research was that actually when you think about a brain injury, and you can generalise this to other areas, when you think about a brain injury, that injury doesn't just happen to one person, it happens to the whole whānau. And you think about diabetes, when someone gets diabetes, it doesn't affect just them, does it? It affects all of the people around them. And they carry ideas about what it means to have diabetes. So our whānau are the same. They have ideas about what it means when you have an injury to the head, you have an insult to the brain. And so for us, it's not just an injury or insult to the meat, to the organ of the brain. It's an injury to the wairua, to the cultural aspect of our identity. So then there has to be a cultural response. So the long
Kia ora. Okay, other questions for Hinimoa? Guys, any questions from the regions? Just put them in the chat. Oh, we got one over here. Yeah, up there. Thanks, Anna.
yeah.
Anna?
Yeah.
Oh, up here. Thank you.
Kia ora. Thank you for your time and effort into this presentation, and I'm sure that we all appreciate you sharing your experiences. Just a question, looking a bit broader, when you look in other countries and how their relationship with their Indigenous population, what do you think New Zealand's doing great, and what do you think New Zealand can improve on?
So are you saying when I look at other, are we talking other Indigenous groups around the world, what can we improve on?
Yeah, like,
This is a really interesting kōrero, thank you. So one of the dynamics around that is that we are often seen as a leadership, in a leadership role to other Indigenous countries. There's some validity to that, or you can choose some examples of that. We have a tiriti, we have a treaty, and so on that basis we've been able to enact and enable activities that help us to survive, really, and hopefully thrive. So oftentimes, and this can be a problem, because oftentimes other Indigenous groups look to us to help with solutions, but actually, in my experience, what I try to do is to walk beside my colleagues from other countries and say, well, actually, this has to come from inside of your history, in your language, and we can totally support that. I'm also thinking in the College of Psychiatry, we've had groups, Māori, Aboriginal, Torres Strait Islander, and often we are called upon to take a leadership role, and actually that's not appropriate, because that's not our whenua. So when I go over to the whenua Moimoia, otherwise known as Australia, to do stuff with our College of Psychiatry, I'm very mindful of our role there to be not in, because often it's the non-Indigenous people who are expecting the Māori to come to Australia and help, but we have to stay in our lane. So that might not be quite the answer you were looking for, but that's, I think there's an important lesson for everyone here. You all have cultural resources that will bring, that you'll have a depth of connection with your patients because of those cultural resources will enable that to come forward. And it will be different for all of you, and it's not like one can do better or differently than the other. It's about respecting that you all have those cultural resources within you and to maximise those.
But I think the common journey of Indigenous populations around the world does allow for a lot of cross-learning, doesn't it?
Yeah,
when they can get together,
we do share a lot. We've had many different kinds of conferences where we've met up together over the years, and we do share our learnings. But I think we all try to maintain that mutual respect and that reciprocity of recognising that we don't want to be involved in a kind of recolonising of another Indigenous group.
Sure. Okay, have you got a question there from...
Yep, we've got a question from Hamilton. It says, greetings from the Waikato cohort, and thank you for your presentation. Just wondering if there are any current, ongoing or recent examples of people rectifying racism in our systems.
Many. Okay, part. I think, I'm thinking about this from an individual and then a team and then a structural wider perspective. So I think on one level, bringing cultural resources into our unit at the moment is about re-indigenising and decolonising that part of Starship Hospital. And we were only really able to do that once we had our Māori name gifted by Rangi Māori, Dame Nada Glavish, who's the head of tikanga for this area. And that was all delayed because of COVID as well. So this is, COVID and similar kind of population problems impact on some of the minutiae, if you like, of activities that were trying to get going but had to be stalled because all the focus was on COVID. And I'm sure Jim might speak to some of the other examples of that, of both of you. So I think that's been one example, is actively bringing in a cultural needs assessment tool into our unit, where 40% of our whānau in our spaces are Māori, and we haven't really had, it hasn't been culturally safe to bring those things forward until now.
Kia ora, thank you. Okay, I'm just going to ask one of these people up here to say thank you to you, Hinemoa, for your presentation. Here we go.
Yeah, I just want to say thank you so much for your presentation, and yeah, I really loved how you talked about having that cultural base to clinical care rather than putting culture into clinical practice, more putting clinical practice into the culture. So thank you so much.
Kia ora. Thanks so much. Here we are, some nutritionally certified chocolates for you.
This is very wrong.
I know it's very wrong, but... All right, kia ora, thanks so much, Hinemoa, for that. And now I'm going to ask Ashley Pereira. Where's Ashley? Ashley's going to come down and introduce Jin, and I'll get her. Signs up, Russell J, that's you.
Kia ora. I have the immense pleasure of introducing Dr. Jin Russell today to all of you. So Dr. Russell is a developmental pediatrician at Starship, a community pediatrician, as well as a key advocate for many of our communities. And on top of this, she's also a mother of two, which is also a really big thing as well too. All of this gives her a unique experience and unique perspective on how children grow and develop, and how the environment and our relationships that we experience as kids influence our lives growing up. She herself grew up in Noah Hut before then graduating from medical school right here in the University of Auckland, attaining a distinction in many, many fields. If I had to name them all, we'd be here for a long time. Dr. Russell is currently completing her PhD with the Growing Up in New Zealand project in the Field of Life course Epidemiology. She believes that inequities in early developmental health can unjustly impact how capabilities form from within our children, and that addressing these inequities is essential to creating flourishing societies. She has won many awards for her amazing work, including a New Zealand Health Research Council Clinical Training Fellowship and a Royal Australasian College of Physicians Trainee Research Excellence Award. And again, if I were to name them all, we'd be here for a very, very long time. Yeah, so can you please give a very warm welcome to Dr. Jin Russell.
Kia ora koutou katoa. Thank you so much for inviting me to speak, Boyd, Anna. I really appreciate it. It's so lovely to be here with you face to face, and it's a hard act to follow, following Sir Ashley and Dr. Hinemoa. You know, Hinemoa is so wise. When I'm listening to her, I feel like I'm drinking water from a fire hydrant. Do you know what I mean? Just trying to catch it all. She's really amazing, and yeah, and it's a shame that she had to leave early. I want to talk to you a little bit about what I'm really passionate about, which actually dovetails really nicely with what Hinemoa was saying. That is that I really do believe that paying attention to children and the needs of children and the needs of our marginalised, the needs of our disadvantaged communities, the needs of our ethnic minority and Indigenous communities is what is the key to unlocking population health And I started out just as a very ordinary house surgeon and paediatric registrar, but then suddenly kind of woke up to population health, and that's really what I want to talk to you about today. Some nice shots of my family and also a little bit about my job. So I was one of those teenagers growing up who just absolutely loved children. I would offer to look after other people's children. I would follow little toddlers around, making sure that they were okay, that they didn't fall over. I was that kind of person. And so when I came out in Middlemore, walked out into my first paediatric rotation, I signed up for the paediatric training scheme within 3 days. So I was absolutely sold. And this is a picture here down below of my family on a very ordinary day. This is what we look like. I've got this little boy here in green, Toby, he's now 6, and Chester is now 8. And Matheson here, my husband is a philosopher at Auckland University, and it's been an absolute blessing having a non-medical partner in my life. So, you know, if any of you here have got medical partners, you'll be all right. But if you have a choice, I highly recommend marrying someone in the arts. And look, I took the longest training route in history, and this picture here is of me at Te Papa on Convocation Day, you know, getting my fellowship. And what it says is there are some of you who will just ace through your training and you'll be out the sausage making factory in, 6 years straight from when you finish. And then there are others of us who take a meandering route. And so when I am introduced, when I'm giving talks, I mean, I'm not old enough in the tooth to be used to being introduced as a sort of list of my achievements. What I wish was that when we went to conferences and when people were being introduced, that we actually introduced people as a list of their achievements, yeah, but also their uncertainties and their doubts. And, those bits of your life which you're just not sure how is it going to make sense. And my journey has been really non-linear. The top picture is a little picture of Oscar. He's one of our Starship stars. He's a little boy with Down syndrome who loves his picture being in talks and on social media. So I have permission from Oscar and his mum Pip to use his picture wherever I give talks. I want to tell you about how I sort of woke up to population health. So here I am at Middlemore. It's over a decade ago. I'm working in a completely ordinary kind of job in paediatric emergency. And one night shift, I just sort of woke up to it. This little girl came into the ED, and she was with her dad. She was Cambodian. Family didn't speak English, so they were there with Uncle, who was translating for her. And she came in with viral wheeze, so I started treating her with a protocol straight away. And as I spoke to Dad, I found out that the house that they were living in was a rental property, and it was damp, and there was condensation on the windows, and there was mold, and it wasn't great. And I also found out that both Mum and Dad were working really hard, working shifts. So if you're working shifts and you've got a little one to look after, that's quite difficult because you're doing handover all the time, and that disrupts continuity for that little girl. I also realised that there were other things going on. Finances were tight. They had English as a second language. And what really got me was when I asked them, where's Mum tonight? Because usually when babes come into ED in the middle of the night, they come in with their mum. So I said, where's Mum tonight? And Dad said to me, oh, she's at work. And I said, oh, what kind of work does she do? Thinking, oh, maybe she's a cleaner, maybe she's a nurse, maybe she's working at the airport. Dad said, no, she's working in a chicken factory. She packs chickens. Now, I had to sit down at my desk and write up the notes. And as I sat down, something kind of hit me. And one of the senior nurses in ED, nurses are awesome at this, just ran over with a cup of tea and a biscuit because I think she knew that I was sort of having a moment. And there was this sort of just bigger, my conscience was sort of awakening to the fact that I lived in a society where we need chicken in the morning. We need to be able to go into the supermarket to buy chicken. And so that meant that people had to work through the night to make that possible, even if it meant being away from their little ones. And it got me thinking about all the ways in which disadvantage clusters and how that might affect not only children's health, but children's development. So, children's cognitive learning development, their capabilities, which all of you have in bucket loads, their social, emotional, and behavioural development, and also their motor skills, their physical health as well. And so I was thinking beyond disease, I was thinking about children's development, and I was kind of waking up to this. And I started asking myself questions like, what kind of factors are happening in our communities and in our society that are impacting upon children's development? How are our future citizenry, their capabilities in early childhood, how is that being shaped by structural forces? How is that being shaped by what's happening at a society level? And what sorts of factors are amenable to intervention? And we know that this is really important because what happens in early childhood has an effect across the life course. So the life course framework is a really important framework for doing population health. It's thinking about what happens earlier on in someone's life actually has this kind of association to later life outcomes. And this is a very famous study from the Dunedin cohort team, which was published a decade ago, where they showed that to the extent to which a young child demonstrates self-control early on, that you can find an association to their later life physical health, their substance dependency, even the amount of wealth that they have, the amount of money they have got in the bank, whether they're in stable relationships or not, whether they have substance abuse addiction and other factors like BMI. So we know that early childhood development is really, really important at a population level. And at that time, when I was kind of wrestling with these big questions, I was looking at literature as well. So I was working, work my night shifts, work my afternoon shifts, and then I'd come home and I'd be reading. I was really geeking out. And this is from a paper that I read at the time, which shows that, if you measure children's development, and you sort of create an index of development and you compare children in one neighbourhood to another neighbourhood, you find that there's a socioeconomic gradient in children's developmental outcomes. So that children who are in the most advantaged neighbourhoods, so this maps onto our quintile 1, so our most advantaged neighbourhoods. In this study of children's development in Australia, about 1 in 6 of those children would be sort of in the lower part of their cohort, so developmentally vulnerable. They're sort of falling behind in one or more domain. And a small proportion of children are developmentally vulnerable in 2 or more domains. But if you track up across to another neighbourhood where children are in the most disadvantaged homes, you find that it's something like up to 1 in 3 children are developmentally vulnerable in 1 or more domain. And now 1 in 6 are developmentally vulnerable in 2 or more domains. And so this is that postcode lottery, Dr. Elder just referred to, the postcode lottery of children's development. And yes, there are a lot of factors that go into this as well. There's education, it's not just poverty, it's education, it's about the parenting styles in those families, it's about family stress, etc. There's a whole lot of factors that go into this. But overall, this is what we see. And I got really concerned by this. And I think what was happening to me was that I was getting used to that feeling of, when you see a patient, when you're with a patient and there's one person in front of you, you want to do everything that you can to help that one patient with the resources that you've got. So you're trying to help that one patient. But what was happening to me as a registrar was I was feeling all these questions around me. This one child represents a community of children. There's a population effect happening here. As I move between Starship, which is more advantaged, Central Auckland is wealthier, out to Middlemore and back again, I could see differences in children's development. And it just got me asking questions, like what's happening with our society here and how can we support children's development to be more equitable? And so, we have a big question, you start a PhD. So I started a PhD with growing up in New Zealand where I gave myself time to actually properly look at these questions. And I just absolutely love epidemiology. I don't know if it's Rod Jackson or whether it's the maths, but I loved that there was this kind of science of population health that I could tap into. And I also loved how epidemiology is not just the domain of health researchers, but it also interfaces with sociology, anthropology as well. Absolutely love that. So, started my PhD, and look, this is one of the key findings of my PhD. I kind of recreated that graph that I showed you earlier and found that it is true for New Zealand preschoolers as well in the Growing Up in New Zealand study. And what this shows you is that as the deprivation increases in our neighbourhoods, the proportions of children who are developmentally vulnerable in one domain, in their overall development, and children who are developmentally vulnerable at age 4.5, it's actually increasing. So in blue, you can see how many children are developmentally vulnerable across that socioeconomic gradient at 2, and in red, you can see it at age 4.5. And you can see that it's kind of getting steeper, right? So that means that the gradient is getting steeper as children approach school. So I have a what's called a portfolio medical career now. I really leaned into these questions that I was having and kind of built a job around those questions and my skill sets. And at some point, I wonder whether this will happen for you too. That, you stop thinking of yourselves as people who are cut out, cookie cutter, for a particular specialty. And instead, you start thinking about yourself as a unique clinician who has unique skills and abilities and questions that you're asking. So, when you're sitting with someone in clinic or you're on the ward or in ED and a person is telling you their story and they're telling you how they got here in front of you, if you're thinking to yourself, oh, I wonder what's going on at home, or I wonder what factors have led to this, or I wonder how our health system might have been different so that this didn't have to happen. Or I wonder how that policy that government put in place 2 years ago has led to this. You're actually thinking in a population health way. So I started thinking like this, and I just basically leaned into it in a big way. So across my week, I now have this very varied and I think quite interesting timetable where 2 days a week on Thursdays and Fridays I work as a developmental pediatrician at Starship, and I see kids in clinic, and I go out to schools and I do clinics in schools, and I love that part of my job. And it's very busy because we're all stretched in clinical practice, as you guys know right now, but I get a lot of energy off of this. And then Wednesdays, 1 day a week, I am employed by Public Health. And I work with a team of commissioners. Now, these are the commissioners who hold the contracts for all of the community child health services across Auckland and Waitemata, and they fund dental and vision and hearing and IMS and primary care providers and mental health and youth line and all kinds of good stuff. And my job is to advise them on how to meet the needs of our population of children in their work. So I do that 1 day a week. And then with the other 2 days a week, I let myself have time to encounter research. I sit in a cafe, often in Mount Eden, just reading papers and letting myself think, how can our system be better? How can we do better as a society? And that's the work that has constituted my PhD. So that's 2 days a week. And I also, because, like I said, I stopped thinking of myself in this kind of, you are a specialist, you're a cookie cutter specialist, this is your job. I stopped thinking of myself in that way and started thinking of myself as someone who's got skills and interests and questions. And that has led me to do quite a lot of volunteer work as well, which I find immensely satisfying. And so, if I've been concerned about the way in which poverty affects children's development, that led me to do some advocacy with Child Poverty Action Group, concerned about how we make sure that we've got population health pediatricians in the future, led me to do medical education, and I've been involved in other work as well. I use population health frameworks every day, and these are some of the frameworks that have really gone the distance for me, and you'll encounter some of these this week. I'm thinking about the social determinants of health, thinking about factors like colonisation and racism and income and education and occupation and barriers to accessing healthcare and all of those socioeconomic things that actually either support or don't health and well-being. and some other frameworks as well. But what I'm trying to get at here is that the frameworks that you learn this week are actually applicable in clinical as well as research settings. Because I was thinking like this, when the pandemic hit, I think I was one of, I don't know how many people there were sitting at home just thinking, I wonder how this is going to affect children, but I was one of those people. When the pandemic hit in 2020, we were really worried about our elderly and our kaumatua, and so we closed our borders and we stayed at home. And there was a lot of korero at that time around protecting our elderly and the disabled. Really important. Those were the goals. But I was at home thinking about how is this going to affect children? So not just how does COVID-19 infection affect children, but how do the pandemic restrictions actually affect children as well? And so because there was a gap and I didn't see many people speaking about this, I just sort of stepped into that gap and started communicating and working in it and connecting to our chief science advisors and did panels, some of them with Hinamoa. And I found myself actually doing a lot of public health work. I started explaining how COVID affects children and why it was important for children to be able to be at school and how families ought to put rhythms in place so that children's well-being was supported. I became really involved in the vaccine rollout and doing communication for the ministries. I was working with schools so that we could help schools open safely in a way that teachers felt comfortable with. So I did a lot of work around this, and that was just because I didn't see myself in this subspecialist way. I was thinking about the population that was going through this and what we needed as a country. And that was quite a lot of work, but you know, we're still standing. One of the best things that I did over the pandemic was to do some specific science communication for children. And this is a piece that I wrote with Dr. Julie Spray. She's an anthropologist and child health researcher. And we wrote to the kids in New Zealand in language that they would understand to explain what was happening to them. This was during the Delta lockdown in 2021. And this was a really popular piece. And we had children actually helping us write this. We had a panel of child experts who told us, nah, be straight with us. Tell us how many children die. We want to know how many children die from COVID. And we had to listen to them. So when you're looking at the needs of the population, you just end up thinking differently and doing stuff that you just you just wouldn't have thought to do. And I'm still looking at this now. So part of the work that I'm doing in public health is to lead insights into how the pandemic has shaped the health of children and young people over the last few years. And now that the acute phase of the pandemic is over, we're seeing more and more papers like this, where we're looking at how infants, for instance, born during the pandemic are almost twice as likely to have communication difficulties compared to pre-pandemic infants. We think this is because they had fewer opportunities to be outside and to speak to strangers and to be at daycare and to be in playgroups. We think that kids coming home from school and being homeschooled meant that parents had less time to spend face-to-face with their infants. And there are studies that are showing, and this is a preprint, mind you, but I think the effect is pretty much there, that there's been impact on children's cognitive development when you have very severe restrictions like they had in New York. That cognitive development scores for infants born during the pandemic actually fell significantly over that time compared to baseline. So this is what I now call the pandemic generation, and we will be dealing with this for years to come. There's learning loss as well. So when you close schools, you get children who are from disadvantaged homes get further behind compared to children who are from advantaged homes. In fact, children who are from advantaged homes can even make ground because they get more one-on-one time. But children who are from disadvantaged homes that don't have Wi-Fi, that don't have desk space, these children get really far behind. And we are dealing with this as well here in Aotearoa. So I keep myself really busy, but it's really fun. And this is really what I want to say to all of you, that anybody can do population health. If you're sitting with one person in ED or in clinic or on the ward and you find yourself asking questions about our health system, about our policy settings, about the community around that person, you are thinking population health. I just want to encourage all of you, because we need you. We need you to think that way. And kia ora. Thank you for having me.
Kia ora, thanks so much, Jen. What a tremendous journey you've been on, and still going on. And thank you for all of your input over the pandemic. That was tremendous, standing up and taking on the role for kids. Okay, now we have Harrison's back. Harrison's going to introduce Dr. Penny Milsom. So come on down, Harrison. Have you got slides? Oh, you've got them. Here we are. Yeah, there we are. Okay.
Hello again, guys. I have the privilege of once again introducing another speaker. So just a bit of information. Our next speaker has a Bachelor of Medicine in Surgery from the other medical school, the University of Otago. And she also has a Masters of Public Health in Health Policy and Management from Columbia University. She's also got a PhD from the London School of Hygiene and Tropical Medicine in Public Health Policy and Global Health Governance, and she works as a pediatric surgeon, so just a few achievements. In 2017, she was one of the few people who heard about the Ebola crisis and ran towards it, working in Sierra Leone, Guinea, and Liberia during the outbreak. She's an executive board member of Orotaia, the not-for-profit working to educate the public on threats of climate change and its effects on human health equity. Her areas of interest include non-communicable disease prevention, commercial determinants of health, climate and health justice, child health equity, political economy and power and health policy making, equitable health systems, and decolonizing global health governance. And trust me, this is just a few. The list of experience and projects she's involved in is extensive, and I could go on all day, but for now, I'll finish up here, and please welcome Dr. Penny Milsom.
Kia ora katoa katoa, koutou katoa. I just spent 1 year at Auckland University, so I'm not a total imposter. So I guess what I'm going to talk about today is a little different from the two speakers we've had before, and I guess I'm going to try and bring a little bit more of a global perspective, which is really complementary to the kind of more national perspective that we've had talked about so far. And I'm going to try and talk about things other than COVID, because there's so many other major global health challenges that I think get lost amongst all the talk and the effort and work around COVID. So I'm going to talk about similar things that certainly touch on very similar things that have been discussed already. So social, economic, and political. What I've called pathogenesis of disease, to try and draw you in, because you're all obviously doctors in training, but bringing a global perspective to that. Do I just click? Is it just this one? Oh no. Okay. So I'm going to sort of talk a little bit about my background, I guess, and then this is the start of your Public Health Week, I think. So I thought it might be useful to just touch on some really broad key concepts in public health and global health, try and link them to specific things that I've done in my work so far, and also why they're relevant to being a doctor. If the vast majority of you will probably end up being doctors in hospitals or in general practice settings. Some of you won't be. Some of you will have more varied portfolio careers like Jen, or very kind of non-linear career pathways like me. But I wanted to also make it really clear how these concepts are very relevant to you as a doctor, and your power and legitimacy, how you can use these ideas, and your power and legitimacy as doctors, and the platform that you have, which it can be very powerful. So this is just a little bit about my background. Weaving the threads of health and well-being at the intersection where everything collides. So I've got very broad interests, as you've heard, in clinical practice, but also broadly across public health and global health. I've done a lot of different things. So I guess one thing to take from this is please don't be scared to take a different path. As Jen said, you don't need to jump out of medical school, jump into a clinical specialty, and do that for the rest of your life. And I think your generation of doctors is going to be one where you don't necessarily do that. Focused on a single path. You know, people do tend to have multiple careers now. So I encourage you to really do that, and don't be scared to do that. Don't feel like you've come out of the sausage making machine and that you've got all this pressure to stick to one thing and only do that, because you will feel that pressure, and you'll feel it from your peers and you'll feel it from your seniors, and it's really important that you do what drives you and what interests you, and if that's not just one thing. And taking time out, spending time abroad and doing all sorts of different things brings humility to your practice. It makes you more respectful of your patients, I think, and those are really, critical to being a good doctor. I think sometimes taking a linear pathway and just doing that one thing, there are other dimensions of your life and your personal development and your maturity, your emotional maturity that can get a little bit lost. So I think taking the time to, in Danish, my husband's Danish, my children are Danish, it's called develop some and that's kind of wisdom, like what we were talking, Jen said of Hene Moana. You know, her wisdom has come from her broad experience. So that's one thing to take with you today. Okay, so this is getting into the more lecture type things. So just some definitions. So the WHO definition of health is the state of complete physical, mental and social well-being, not merely the absence of disease or infirmity, an old-fashioned term. So we sometimes get, very obsessed with physical health, but it's much broader than that, and we need to bring well-being into it as well. And of course, mental health, which often gets neglected. Global health, there's multiple definitions of global health. For me, a useful way of thinking about global health is that it's a multidisciplinary science and practice, and it takes a preventative approach to addressing health challenges that transcend national borders and that require international cooperation to manage and address. So global health is not going to a far-flung place in an African country and working as a doctor for 2 weeks and then leaving again. To me, that's not global health. What I'm going to talk about today will hopefully draw out this definition a little more. I think it's important to state my normative position, where I come from in the work that I do. I believe in the universal right to health and well-being. I believe in health equity among nations and also within nations. And I also believe in a health justice approach. So health equity, we're not necessarily dismantling the systems and structures that create health inequities. We're just supporting people who are the most disadvantaged in that to come up to a level of everybody else within that existing system and structure. Health justice is dismantling the systems and structures that cause those inequities in the first place, so that we don't need to support some people more than others. Of course, in reality, that will always probably be necessary, but having a vision of health justice is, I think, really important. All right, so this is a term I'm sure you'll come across this week, or I hope you will at least. The social determinants of health inequities, and Jin's talked a lot about them. Hene Moana's talked a lot about them as well. I guess this just brings more of a academic structure or conceptual kind of framework that you can place them all in. On your right, you've got the WHO social determinants for health framework. And on the left, you've got Dahlgren and Whitehead, and back in 1991, they developed the ecological health framework. So social determinants of health are the conditions in which people are born, grow, work, live, and age in, and the wider set of forces and systems shaping the conditions of daily life. So every patient that you see is in the time at which they've come to see you, so much of why they're there is because of the environments in which they live. The patients that I see at Starship, they embody the environments in which they live. We see, obviously things that could have been prevented long before had they had the parents been afforded to go to the GP to get their kids some antibiotics early on. Just the numbers of, just very basically, the numbers of abscesses that we drain in the operating theatre that could have been managed by a simple short course of antibiotics had they been, had that child been able to get to the GP earlier. That would save, I don't know, thousands of hours every year of operating time. And that's just one very small example. There's multiple examples like that. And Jin and Tenemoana have also touched on multiple other things in their work. So the social determinants of health are critical, and you will see, every patient you see will embody the social determinants of health. So I thought just to bring some reality to what that means and a little bit of a different perspective. The Ebola outbreak that took place in West Africa in 2014, between 2014 and 2016, that was an outbreak that I was involved in. So Ebola disease has a 50% mortality. So if you're infected, so it's that can be much higher in places where there's very weak health systems. So it's a very frightening disease. And there was an outbreak in West Africa back in 2014, and the international response was incredibly slow. So there were literally people lying in the streets, or dead bodies. People were finding dead bodies in the streets. And I think MSF was the first organisation to go to West Africa and start trying to help and set up Ebola treatment units. And then some months later, different organisations came and started setting up Ebola treatment units and providing technical support and so on, and all the things that are needed in an emergency response to an infectious disease outbreak. But what I just sort of don't want to talk about that. We've talked a lot about infectious disease outbreaks today, but I think what's important to think about is what drove that outbreak. Ebola outbreak isn't caused because Africa is a place where they have a unique propensity to disease for any other reason other than the social determinants and the structural determinants of health. Poverty, as you can see, the pictures that I've put up today, kind of poverty driving, we know there's widespread poverty in the global south, food insecurity that drives people into the bush to collect bushmeat or hunt bushmeat to eat. So Ebola came from bat, and people in West Africa were eating bats, partly because of issues around food security, not having enough money to buy food. So that's how it first got transmitted, and then the Ebola outbreak continued to get more widespread and perpetuated by limited access to all sorts of things, limited access to education. Lots of the people that in West Africa couldn't read or write, so any information you tried to give about Ebola, they weren't able to read it. So you'd have to be very careful about how you provided that information, and just to understand that the transmission of disease was quite difficult for some people as well. Obviously, a very weak public health system, no surveillance and control, and then weak health services themselves. The entire health system collapsed, hospitals closed, local health, like general practice type settings were shut down. So we had people who were not only dying from Ebola, and thousands of people did, but many, many more people died of non-Ebola related diseases. And a lot of that was also a lot of pregnancy-related complications. So maternal mortality went up hugely during Ebola because of the parallel collapse of the regular health system. And there were things like social and cultural issues that also perpetuated the Ebola outbreak, things like traditional burial practices. Touching a dead body is a particularly bad thing to do with Ebola because the bodily fluids have high concentration of viral load, and so in traditional burial practice in West Africa, there's a lot of touching of the body, embalming the body, and so that was another way that it got perpetuated. So there were multiple social determinants and cultural practices and so on at play that drove the epidemic. I call it an epidemic because, yeah, it was 3 countries. It didn't really go too far. I mean, there were a few cases beyond that, but it didn't go out of control beyond that. I just thought I'd put up some pictures to show you what it was comparing, kind of, you know, how things were with the COVID outbreak. I know things were bad globally, bad in New Zealand with the COVID outbreak, but this is what was happening in West Africa with the Ebola outbreak. You know, erecting these very makeshift Ebola treatment units. Quite late in the outbreak at this point. Hospitals. This is the hospital that I worked at. This was the first hospital in Liberia to have an Ebola patient in it, and as a result, many patients died in that hospital. Many staff died of Ebola, and the hospital was abandoned and then sort of stoned and attacked by the community because they, you know, felt like it was a place that had brought Ebola into their families and communities. So it was completely deserted, and meanwhile, women and children, and obviously men as well, were suffering from regular health, all sorts of not usual health problems, communicable diseases and non-communicable diseases and maternal-related health problems in the community while their hospital was just completely non-functioning. So I worked with the International Rescue Committee, and we worked closely with the Liberian government and the hospital management to bring this hospital back to life and make sure that it was safe, as safe as it could be, with Ebola infection prevention control strategies in place, and so that we were able to safely as possible provide regular essential health services really during the Ebola outbreak. This is the hospital, Redemption Hospital. This is just some pictures of the cleanup going on to get it up and running again. These are some of my fantastic colleagues from Liberia, but also the African Union. African Union provided thousands of doctors and nurses to come and work, and during the Ebola outbreak, where the West was not, or the people from the global North were not acting so well. So that's Philip, who's kind of like this. He was a paediatrician who was one of our team leaders, talking with some of the nurses and the hospital staff there. I don't know what they're arguing about. This is the pediatric department once it sort of got back and running again. That's some of our cleaners who did the hardest, most dangerous job, transporting dead bodies and doing disinfecting areas after they've been contaminated with COVID. This is the Ebola isolation unit that was set up by MSF next door to where we worked, so that when we triage patients, if we thought it was a child or adult who had the symptoms or fit the case definition of Ebola, they would go to the Ebola assessment unit, Ebola isolation unit next door, be tested, and then if they tested positive, they'd be treated and transferred to an Ebola treatment unit. If they tested negative, then they would come to us. So obviously you can see the IPC there, which everybody has but now become familiar. It was pretty strange back then. I guess everybody's now become somewhat familiar with it, with Ebola, with COVID. And this is a picture of the team, or some members of the team who were working in Redemption Hospital. And I guess just to say, I don't want to put up photos of, poor, sick, little-looking African children or things like that. I'm not all into kind of tragedy tourism or tragedy porn, but this is just to say the strength of the local African response was immense, and when resources were put into the hands of locals, local government, but also local communities, that's when the response really turned around. That's when we started to be able to get in control of Ebola. And many of the lessons that should have been learnt from the Ebola outbreak that apply to the COVID, would have applied very well to the COVID response, unfortunately weren't learnt or weren't taken on board early on. No one turned to the African countries at the start of COVID and thought, oh, they've had a lot of infectious disease outbreaks there, how have they managed to control them? But these lessons that everybody's sort of coming out and saying now that we've learned from COVID, they could have been learnt much earlier on in the outbreak if we'd looked to the global south for and drew on their experience during the various infectious disease outbreaks they've had. So there's certainly a lot of racism still that goes on in global health. And I think that was an unfortunate outcome of racism and global health, that we didn't learn enough from the Ebola outbreak early on during COVID. There's some of my beautiful, beautiful nurses that we worked with as well. So just moving on, it's probably my time out, but I'm going to talk a little bit more. I wanted to talk now. So we talked about the social determinants of health, and Jen talked about them as well. And I want to kind of take another step back to the social, structural and political determinants of health. So these are kind of the structures in which decisions are made and policies are made. And you know, it can seem a little, you know, what does that really mean? So the condition, there's kind of the causes of the causes. So what are the conditions what are the political conditions and the structures in which we live that drive poor education, that drive poverty, that drive socioeconomic inequality? And I just put some different pictures up here to just draw on some significant examples. So in the global context, I guess. So when we think about, you know, we think the global south, it's a very poor, you know, part of the world. Why are they poor? You know, it's not inherent to being from the global south. There's been, you know, colonialism, extractivism that's impoverished these countries. There've then been structural adjustment policies through the international financial system that has driven a dismantling of social systems and the social support systems, health systems and education systems in these countries. For example, the IMF, the International Monetary Fund, and the World Bank would only loan money to these countries if they agreed to reduce their social spending. And so now we've got situations where these countries are stuck in huge debt, and they've got to finance this debt. And so they end up, because of the structure, the way that it's set up, the debt repayment systems, they end up, for every dollar that they gain in not in grants, but in loans, they lose more than $2 in terms of paying back. So all the money that they're trying to pay back to service these loans, they're not able to put into their health systems or their education systems or their social safety nets. We have WTO agreements. That's World Trade. That's a World Trade Organization that is the governing body of international trade and investment. International trade rules affect access to medicines. They affect policy space for NCD prevention, and you know that came up. Particularly the access to medicine, medical technologies and diagnostics came up during the COVID pandemic, and we saw South Africa and other countries trying to push for a break from the obligations that countries have under the World Trade Organization agreement in terms of intellectual property, so that we'd be able to increase access to medicines and technologies and diagnostics for COVID, and they tried to drive for that and they didn't get that, and we've seen the Global South have much lower access to vaccines and diagnostics compared to other countries, and I think that's something that's often, you know, it's really lost when we're so, and you know, thinking about our own context. So the structural and political determinants of health are really thinking about who's got power, who's at the decision-making table, and whose voice is heard at the decision-making table, or whose voice is valued, and whose interests are really, are we making these decisions, whose interests are we making these decisions and for, really. I'll move on. I could talk about this all day, you see, that's a problem. This is just looking, structure, this is a specific example in terms of the structural determinant of health, so trade and investment agreements. I won't go into this in detail, but there are multiple elements of trade and investment agreements that affect health in terms of affecting our exposure to risk or risk factors, protective factors, and then the health outcomes. A lot of work, and particularly my work in particular, has been looking at ultra-processed food and highly sugared drinks, sugary beverages, tobacco, alcohol, those things, and how international trade investment, the international trade investment regime affects access, ability to make policy to prevent the impacts of those things on public health. It's quite a bit of a boring slide. I want to touch briefly on the commercial determinants of health. This is really throwing some things at you. So the commercial determinants of health, we'll leave the other things behind for now. The commercial determinants of health, but they are all interlinked, are defined as the system, practices and pathways through which commercial actors drive health and inequity. And we, particularly the practice of large transnational transnational corporations, I should say. So they are responsible, so 4 industries, fossil fuel industry, tobacco, ultra-processed food industry and alcohol industry already account for at least a third of global deaths, illustrating just the enormous impact that these corporations have on health. And the patients that you see, you'll see so many patients who are affected by alcohol and having unhealthy diets because they've consumed too many ultra-processed foods, because that's what's cheap to buy and that's what is easy to prepare and things, because they're overworked, they don't have time, they don't have money. So these are all really, these may seem like kind of out there concepts, but they're all super relevant to what you do in your clinical practice. I'm not going to go into detail, but if you're interested in the corporate determinants of health, there's a really great Lancet series that's just came out on the commercial determinants of health, and you can find that framework there. The last thing that I wanted, the kind of last concept I wanted to talk to you about was thinking in systems. So when in medical school, so often we learn to think about, sort of take an individual approach. We see patients individually. We're thinking about the sort of biomedical model of health. We're trying to, particularly when you first start out, you're just grappling with, gosh, what's the dose of tramadol? What's the dose of, what antibiotic should I give here? Those kinds of things. But once you've got to grips with those things, I think stepping back and thinking a little about the systems in which your patients are embedded. We've talked about that from the social and structural and political determinants of health perspective. Thinking in systems is linked to that, but thinking in systems really thinks about how the drivers of health inequities are interlinked to each other. It gets us to think about how particular lock-ins in the system are perpetuated. So what are the dynamics of the system that drive us to not be able to change health inequities? Why is it so hard for us to improve Māori health, for example? So thinking in systems is super important. I've got this, they're a little bit daunting, these system models, but this is just to give you a sense of all the things that drive childhood obesity and how they're linked to each other and how they drive causal chains of impact. And the things that you'll see, for example, in ultra-processed, because of the ultra-processed food system, some work that Boyd's leading at the moment that I've been involved in, what the end of that game that you'll see is obviously obesity and non-communicable diseases. So all relevant to what you do. This is just the last thing that I wanted to put up, a systems model of the impacts of climate change on health, which is another enormous, one of the greatest global health challenge we face currently. And the impacts of climate change on health are multiple. So if you're interested in climate change, don't think that if you're a doctor, it's out of your lane. It's very much in your lane. So just to wrap up, bringing global public health perspectives into your clinical practice, I really urge you to shift from an individualism paradigm, and that we learn that in medical school because it's so competitive and you're so focused on your own study and your own improvement and your own betterment, and I've got to impress this consultant, and I don't want to look like an idiot when I'm put on the spot to answer a question in front of a patient on a ward round, those kinds of things, to get on competitive training programs. I think medicine can become so much about how good am I for my own, to maintain my own confidence and maintain face or keep face amongst colleagues and so on. But I really urge you to shift from that kind of individual mindset, which does get perpetuated within the sausage factory of medical school, and shift to thinking about this, thinking structurally. And I think that also gives humility in your practice. You see a patient, you don't think, oh God, another overweight patient, God, they need to stop eating so much. They're overweight because of the obesogenic environment in which they live. It's not because they don't have enough, individual will to not eat that McDonald's, McDonald's 3 nights a week or whatever it is. So humility and respect for your patients, I think, can come from bringing that structural or broader approach to your patients and thinking about the environment in which they live. Thinking in systems, the interconnectedness, and then the lock-ins and the synergies that are created from systems. So there's lock-ins, but there's also ways that doing one thing can have multiple co-benefits. So when we think in systems, that helps us to identify those things. Embedding a decolonial and health justice approach. So whose knowledge is valued? We've heard from Hene Moana today that Māori health, we haven't, Māori culture and knowledge and worldviews, it's not been prominent in our health system, and that's, it should be. Whose culture dominates? This is all very true in the global health context. Who benefits, and what system? We need system and structural level change. It's not only, we can't just think about, I'm going to learn Māori and I'm going to say kia ora when I see my patients. Those are important, but it's about what is our position as doctors, as powerful people in our society. What is my role in dismantling the structures that essentially oppress Māori, and in the global context oppress people from the global south and other Indigenous peoples. Don't feel overwhelmed. Systems and structures that we live in, they are socially created. They're not concrete. They're not immovable. We've created them. Our societies, people, we've created this, so we have the power to change it. But they require collective action. So lastly, even if you end up being a cardiologist, or if you end up being an endocrinologist, or if you end up being a surgeon, I urge you to advocate. When you have time, when you've finished doing all your exams, or when when the daily load of being a doctor, which is heavy, when you can step back from that a little bit, I urge you to use your platform as a doctor, because you are respected people in society, you are respected by politicians. Use that platform to advocate for change at the social and the structural level, policy change. And those things it's not only for the world, that'll help you as well. It takes the pressure off the health system, and it takes the pressure off you as doctors in working in overloaded health systems. So if you want to become a public health doctor, feel free to come and talk to me.
All right. Let's try this one. Okay, here we go. Okay, thanks guys. Listen, we have run over time, so apologies for that. We're going to have we don't have that much time for Q&A. I'm just going to ask for any particular burning questions, or question for Jin or for Penny. Before we go, and then I'm going to ask, both of these people have done absolutely amazing things. You've heard about the non-straight lines, about the weaving lines, bringing in clinical and public health approaches, global levels, local levels, and everything. Any comments or questions from anyone? Yep, got one up there. Okay, we've got a couple of paediatric people here. I'll start with Jim.
Kia ora. I actually hadn't heard that, so I suppose I just have to go through the fire. Yes, it is daunting, and I think what helps in paediatrics is working on your communication skills. You'll find that paediatric nurses and paediatric physicians tend to be excellent communicators, and there's a bit more pressure, and a little bit of that is because you're often in a situation where you're treating a child who can't speak for themselves, but they have a caregiver or a parent or a guardian who is there, and you need to deal with that person really well. But anyway, I really encourage you, if you are interested in paediatrics, don't be put off. It is a wonderful specialty.
Keep hold of that one. One more question here.
Kia ora. Hello?
Yeah, it's working.
Oh, it is? Thank you so much. It's been so inspiring hearing from both of you this morning. It's really interesting kind of taking a step back and looking at these much bigger population health issues. but they can be, I think, very intimidating and often very slow to see progress. So what do you both do to stay inspired and look after your own mental well-being working in these spaces?
All right, you can start with you, Penny, on that one.
Yeah, that's a good question. Yeah, I mean, of course, it absolutely can be daunting, but I would encourage you not to make that a reason that you don't engage with these issues or work on public health. I think working with people who also care about these things is, you get energy from them and inspiration from people around you. I think also having that combined clinical and public health perspective, you see patients and you see the things that are affecting them, and that makes you want to, that's motivating, I guess. In terms of self-care, did you say self-care?
Yeah, looking after yourself.
I've got 2 small children. I think I might hand that over to Jen.
Okay, Jen, what's the magic answer, Jen?
So over the pandemic, I took up tennis because there's nothing like smashing a ball. Look, at a personal level, when I come home, I take my stethoscope off, I put it down, and I am 100% with my kids and with my family. And that just tops me up. So whatever that thing is for you, whatever that thing is, just take your stethoscope off and give that 100%. The other thing is, I understand that it can be intimidating to hear from people who Penny and I are just a little bit further on from you, okay? So like it wasn't that long ago that I was sitting here. Don't feel like you have to carry the whole of Te Whatu Ora health system yourself. Look around you. There are amazing people in this room and ahead of you. So feel like you are just, your unique skills, energy, passion has a place. So just keep looking for that.
All right, folks, I'm going to wrap it up there. I'm just wondering if Georgia Moate, is Georgia here? Georgia's not. Oh dear, Georgia. Okay, who's next down the list? What about Patrick Wong? Is Patrick here? Okay, Patrick, can you just wrap up and thank these 2 wonderful doctors for what they've given us today? Thanks.
Thank you so much, Dr. Russell and Dr. Wilson. I know you guys are incredibly busy, so thank you so much for taking time off to speak to us and just giving us such passionate and good presentations. Thank you.
Kia ora, thank you. Okay, folks, we're running over time. I'm going to let's get back at past. Yep, and.
I just wanted to say that...
Go ahead.
Yeah, thank you. Got some free tote bags and notebooks left over from the NZMSA conference over the weekend, so I'll be up there giving them away.
Oh, good man. And grab those on the way out. See you at 1:15. Can you put that on the... Kia ora, kia ora. All right, guys. Promise I wasn't trying to be a Putin and keep you late because of power plays. I had a last-minute ethics application to submit before 2 o'clock, which had a couple of glitches. All right, let's get into talking about what we're going to be doing this weekend. Sorry, at the outset, I should have acknowledged MAS, which is the Medical Assurance Society, and the New Zealand College of Public Health Medicine. They have they'll contribute to the prizes that some of you will get at the end of the week in your presentations, and I'll talk a little bit more about each of those organisations, important organisations, at the end. Right. The week ahead. Well, guys, what a start, you know. Ashley Bloomfield, what a story, what a stellar public health career. Fantastic of him to share his ups and downs and his course and the different areas, many different areas of public health that he's worked in. So you can see from the screening to the guidelines to the infectious disease, the international rule making, through to COVID and everything. Just so many different aspects of health that he has touched on in his career. So that was fantastic. To hear those three amazing women who have done such a huge amount in their time. And you know, some of them saying they were just only sitting here in these seats seems like yesterday. I mean, they've fit in such a huge amount in their time. But I hope you can see from that the amazing way that they have managed to weave population health and clinical medicine together. I still don't know how Penny does it, you know, the connection between paediatric surgery and Ebola, but maybe I think she's probably still on a journey herself. But so that kind of global health perspective, that's population health writ large on the global scene. And as she said, it's not flying into a poor country and doing a couple of weeks of doctoring and flying out. That's not global health. You know, I do global health from down in this corner of the world without necessarily leaving the country, because we're dealing with these global drivers of our systems, our societal and commercial systems, which influence our health. Okay, now let's get down to the practicalities. Enough for inspiration and big pictures. What are we going to do this week, guys? All right, so I'm going to take you on a bit of a run through the logistics of the week. We weren't going to do a Canvas tour, but Anna's going to talk a bit about where you find stuff on Canvas. And then I've got a whole bunch of concepts for thinking about population health, and a number of them have been mentioned already. Frameworks, ways of thinking, theories. They might seem a bit fuzzy-wuzzy. They might seem a bit, ethereal, but actually they're really practical, useful tools. All right, so this is the one we're up to, telling you what's going to happen, and then at 3 o'clock you're going to be meeting with your facilitators. When you meet with your facilitators, you'll have to get your group oriented to the task, and one of you will need to start calling the agencies that you're going to be meeting tomorrow and the next day. So on Tuesday and Wednesday, you'll be meeting with agencies, you'll be researching the topic. Thursday, you'll largely be developing your project, finalising that, getting your presentation together. On each of these 3 days, I want one person from each group to come and join us in a Zoom at 12 o'clock, where we just go through all the groups to see where you're up to and any questions and issues that you have. On Wednesday at 10 o'clock, I think, isn't it? 10 o'clock, the Population Health in Action? Yep. Something like that. 10 o'clock, I should have put the times in there. Those of you in Taranaki and Waikato and Bay of Plenty will go and meet face-to-face with some public health physicians, and you'll hear about what the day in the life of a public health physician is. People from Auckland will meet here, and people from Pukawaka will beam in to us like they're doing today. And then on Friday, you're going to be presenting your strategy that you've developed to in one of five streams. Okay, so we've put you into groups. There should be about 8 or 12 within a group. 26 groups. You've been given a topic. You've been given a group. You don't have any choice in that. And you've got a group assessment to develop and present at the end in those 5 streams, and there'll be 1 winning team per stream. So at 3 o'clock, you're going to meet with your facilitator. So your facilitator will have a background in public health, not necessarily a public health physician, but this is one of the things about public health, is that if you go over into the School of Population Health, people have come into population health from economics, from geography, from sociology, from medicine, from nursing, from lots of different angles to come into this space of population health. So it's not a doctor-exclusive space at all. So these facilitators, they'll all be public health experts, but not necessarily an expert in your topic, or not usually an expert in your topic. That's not their point. You've got an expert you can call on, but their job is to help you to work cohesively as a group and to guide the development of your campaign, give you some feedback. Meeting on Monday. I want one of you within each group to be the liaison person with your facilitator. So the facilitator has one person that they deal with, and you check in with the facilitator on the Tuesday and the Wednesday to see if you want to meet with a group, if there's any value in that. So you negotiate that with your group facilitator. On Thursday, we do ask them to join you and to hear what you're putting together for your presentation and your ideas, so that he or she can give you some critique and some feedback on that. And at other times, just negotiate that contact. So those are your facilitators. You should have rooms allocated to meeting those facilitators, and that's all on Canvas. Okay, these are the topics that you're going to collectively engage with, and you can see that this is a very wide range of very tough public health problems that smart people and groups and experts and international agencies have been working on for decades and struggling to get any solutions. They're what we call wicked problems. So a wicked problem is something that is complex, that is causing problems, and that is very resistant to policy change. Because it is so big and complex, it's very resistant to change, and so it just keeps happening. So nevertheless, despite those challenges that we're giving you, that these are big, gnarly projects, you're going to have a good crack at trying to get a hold of them. Now, we've got 2 new ones this year. We've got Rainbow Health in Auckland, and we have Death and Dying in Waikato. So any feedback from those groups on those ones, because we're testing these out as new topics, would be welcome. We've got an evaluation at the end, of course. So you have been allocated, each of your groups has been allocated a list of what we call agencies. So these might be NGOs, community organisations, what we used to call DHBs, but bits of Te Whatu Ora, public health units, schools, local government, and so on. So Anna has been putting an unbelievable amount of work over a year to get all of these agencies, about 7 to 10 agencies, organised and booked for you people over the next couple of days. These agencies are giving their time and to you, so we need you to respect that We need you to go and listen and hear what they're saying, ask them intelligent questions, and be guided by the questions that what you need for your campaign. Don't go charging in and say, oh, listen, we think we're doing this campaign in this area. What do you think of that? No, you're there to listen and understand what they do. They're extremely important within the health system. You don't get to see them when you're working inside a hospital, but they're really part of it. So they're giving their time for you, so just be respectful for that. And then we have topic experts. So these are usually academics. They're usually in this university, but not always. They're usually working in population health. And if you need any content expertise, then this is the person to go to. And we have an appointment set up for the expert, but the expert knows that if you want other content input and advice, then you can contact them. So just negotiate that with the expert and about what you might need. In Canvas, there's a set of relevant papers and reports, so we've already prepared reading lists for you. Quite a lot of reading. You're going to need to allocate people within your group to go reading. And as I said, you need to make the arrangements to meet with, you make the arrangements to meet with a topic expert outside the appointment that's already been made for you. So you've got facilitators, you've got agencies, you've got topic experts all working for you. So this is the assessment, this is the campaign that you're going to need to develop. What we want to hear by Friday is a compelling campaign to improve an aspect of the societal conditions or the systems related to the problem or what's preventing the problem getting resolved. So you've been given big, difficult subjects. You're only going to be able to pull a piece of that and try to think about what can be done. I'll talk a little bit more about the boundaries around that campaign. So we need a few things to be submitted. We need a written report on the campaign. That's from the group. That's short and just filling in some notes about that. That needs to be submitted by the end of Thursday. You'll have individual worksheets which you'll need to submit. So that's just to demonstrate that you have fulfilled the requirements. Each of you has seen at least 3 agencies, visited at least 3 agencies or communicated with them. And you'll make some commentary about the workloads. You're working in a group. We expect a fair distribution and allocation of work across the group. And at the end on your individual worksheets, we want you just to assess whether there has been a fair workload. And we also ask for your permission to be able to use your video. So we'll be videoing all of your presentations. We'll be sending those out back to the agencies that you've seen so they know what campaign you've come up with. We'll be sending them to the topic expert and your facilitators, and then the winners of each team will be going up on next year's canvas for the next cohort coming through to look at and see how smart you guys are. So we need your permissions for that, so if you can just sign up for that, and that needs to be submitted by the end of Thursday. And then you've got a bit of time on Friday morning, but we want a PDF of your slides as well on Friday. So somebody needs to be allocated to make sure all these things get submitted. This is a pass-fail venture, people, and it's a group work. And it's the oral presentation that decides that. Once everybody has met their requirements of attending these sessions, the population health in action, the agencies, and so on. So you'll have a 15-minute presentation, about 12 slides, and then some questions. That'll be assessed. There'll be 2 assessors who'll be assessing your presentation, asking you questions, and there'll be 1 winner per stream. So 5 teams will become winners. Now, I encourage you to apply for distinction. Requires a bit of extra work. But if you've got anything out of this week, or if you've got any kicks or insights, I encourage you to apply for distinction. So that can be either a creative work, I'm amazed about how a bunch of medical students can be unbelievably creative. So let's see all your creative juices flow, or it can be an academic essay, 1,500 words, and we need that to be emailed to Anna by the 19th of June. So you've got a couple of weeks after the end to send that in. Those winners on the creative or the academic essay, we've got an arrangement with the New Zealand Medical Students Journal, and they will look at them for publication in the journal. So you might get publication out of that, which is always good for your CV, people. So I encourage you to apply for distinction. So I don't know how much group work you've done in your courses so far, but your whole life henceforth is going to be working in teams and in groups. And so this is actually an important part of this week, is learning how to operate in groups. And you heard quite a bit, I think, from Ashley about the value of teams, about what team leadership means, how you work in groups, what your contributions are. You even heard from Ashley's daughter a few sage words of advice about working in a team and going beyond your job description. So when you meet at 3 o'clock, you're going to do a round with the facilitators, just kind of introducing yourselves to each other and to the facilitator, and talking about what your strengths are. What do you quite like doing within a group? What are the things, what are the particular roles that you could see yourself doing? And there's lots of different roles here. There's a lot of organising roles, the timetabling, the Zooms, the agencies, the rooms if we need rooms. Chairing. Now, chairing doesn't mean being the boss. And Ashley repeated this point as well. Chairing means facilitating a process. Sometimes that process can be a bit tough and you need to navigate that process. So that's the role of the chairperson. Doing the research, hitting those documents that we've, those reports and papers that we've put in the readings. Liaison with the facilitator. Liaison with the coming to the midday sessions, liaising with the topic expert or with Anna, writing the reports, taking the notes, developing the slides, doing the presenting, answering the questions. All of these are different roles, and you need to state which ones you're going to put your hands up for, but be flexible as you go about the week. Okay, so today, you, in your meeting with your facilitator, you're going to be doing the forming part of the forming, storming, norming, performing process you're going to go through. So the forming is orienting yourself to each other and to the task, working out what you've got to do, getting that into your heads. Then the next day or so, the next couple of days, you're going to be storming. You're going to be listening to agencies, but ideas are going to be going through your head about what your campaign could be, and you're going to bounce those and push those out. In this storming space, you're in an accepting mode. This is just ideas that are landing on the table. Don't toss them out early. Just brainstorming means taking on all ideas, and gaining trust and resolving all these conflicts. By Wednesday, you should be cooperating. You should be starting to converge a little bit. You should have a broad idea around what your campaign is likely to be. And then on Thursday, you're polishing it and you're performing in front of your facilitator so that you're ready for the final performance on the Friday. So this is a process that if you're developing some big plan or set of actions, this might take months or years, but you've got a week. All right, so your presentations, 15 minutes to present, 12 slides as a guide. There's lots of resources, and you've probably got a bit of experience about how not to do PowerPoint slides and presentations. So legible font, few images, minimal animations, having presenters who can tell the story, practicing telling the story. That's why I'm getting a few of you just to think on your feet by asking you to respond to some of these to the presenters. You know, in our role as doctors in this community, We're expected to show leadership, as Penny and others have said. This is a very, very privileged position, and we need to be able to think and talk on our feet. And I think the presenting in front of a group, even if it's in front of your own peers, can be pretty nerve-wracking for a lot of people. But it's only practice, and I encourage you to give it a go and to practice and put yourself forward for that. And there might be people who might answer the questions. Some people do the presentations. You might have 2 people sharing the presentation. It's up to you. And then you'll have a couple of people answering questions. And so the others in the team should be throwing questions at you to see, at the question answerers, to see how quickly they can think on their feet and respond to questions. So practice that. And get a few curly questions for the others that are presenting, the other teams in your streams on the Friday. Throw them some curly questions. You've got to practice asking questions. And that's, again, part of the reason that I threw that rather nasty thing at you, just picking you at random to respond. If you know you're going to have to ask a question, or you might be asked, you are paying attention to what the person is saying. You're thinking through what they're saying. You're running the cogs in your brain and thinking about, what does that mean, and how do I then interpret that, or what should I ask them about? So, really practice that and don't be afraid of it. Okay, 1 winning team per stream, and you've got some vouchers from those 2 organisations as a prize. Okay, so here's your task. There's a health philanthropy, and the health philanthropy that I'm thinking of is one that came from the Medical Assurance Society. So this has been an insurance doctors started for doctors over 100 years ago, insuring themselves, and that's been a kind of a collective organisation. What do they call it? A mutual organisation. And then a few years ago, they decided that they were going to create a charitable foundation that they give a couple of $1 million to every year to give away. And I happen to be on the board of the Maz Foundation, and so I've really got the Maz Foundation in mind when I'm thinking about your task. So we have $500,000. We've got $500,000 that we want to be able to give to a campaign. So a campaign, by definition, has a start and it has an end. You're just trying, it's like a project. You're just trying to achieve some purpose. But the purpose that we really want you to achieve is a really, really hard one. We really want you to see if you can make a difference in some way to the occurrence of the problem, or some part of the problem that you're dealing with, related to your topic. So you're going to only be able to bite off a small piece of this, but having identified what the causes of the causes of the causes are, dive into that and see what you can change. Okay, and you've got to convince the board, which is medical and non-medical, and has Māori and Pacific trustees. So on each of your assessing teams, when you do your presentation, there'll be either a Māori or Pacific person. So you need to be able to speak to equity, and you need to be able to speak to how this might influence Māori Pacific down the line. And we want to see leverage for change. We want you to take this bit of money and apply it with laser sharp focus to try to shift a part of the system so that it's not causing so much damage that it has in the past. We don't want any campaigns targeting at the individuals who have the rheumatic fever, who have the alcohol problems, who have the addictions, who are using illicit substances, not the individuals. And they might be, that might be a small part of your overall campaign. It might be, you might want to get some media out there or whatever to get a bit of public discussion about it, but not specifically targeting those people who are copping the end-stage disease or the problem. Also, I know you're working in health systems, and that becomes apparent, and it might be a little bit hard to get away from thinking in health systems, but if you can think up into the societal spaces, that's even better. Okay, so a campaign is like a project. It's a whole planned exercise, like a military campaign. So you need to get your evidence, your rationale, your aims, target groups, who are the change agents, who carries the power, who's got the hands on the levers of power that can make a difference. How are you going to get to that person, those people, that group, that committee, that organisation? Who are your allies? Who are your opposition? You'll have different messages for those. Strategies and actions, measures of success, timelines, budgets, expected impact. This is a hell of a lot to be able to pack into 15 minutes, folks. And these are the kind of strategies that we're talking about. Now, some of these may or may not be familiar to you, but these are the kinds of things you're going to need to think about. How do we create the evidence base? Because sometimes evidence can really shift the needle. How do you build relationships and networks? Relationships and networks is how influence travels. And, you know, Ashley said 80% of your interchange when you're dealing with people is built on your relationship. Relationships are critical, so are networks. Convening allies, creating coalitions so that multiple voices are more powerful than just individual voices. Developing the materials, disseminating the messages, drafting policies, advocating for the policies, monitoring and accountability systems, who's going to hold these people to account that they will make those changes, influencing the organisational culture and systems, cultivate the champions, training programs, see if you can avoid apps, but I mean, maybe an app might be in there, but I just reviewed a paper last night on a systematic review of apps and what value they are in changing behaviour. Pretty marginal, really. So don't go crazy on apps. Lots of different strategies that you won't be thinking about in your clinical practice, but are really important in population health. Okay, so we've got those 5 winners, as I said, from last year. Take a look at that. For those people who have the same topic, don't go plagiarising last year's guys, even though they're winners. But you'll be able to see from how they perform what we're expecting, the level of presentation we're expecting. How to build a campaign. I've got a recorded presentation on Canvas. They're paying attention to the size of the budget. I don't expect you guys to be accountants, but I don't want to see any marketing through TV ads. That'll blow you $500,000 in the first night. You know, the idea of a budget is to just be able to get a sense on what is your capacity to be able to make a change. What's your capacity to make a change? You know, if you're going to pay somebody $100,000 for a year, then that's 100K gone. That's about a health promotion worker, a communicator, an advocate, or someone like that. So think about those. So the budget's not to go down to the dollars and cents, just to make sure you don't blow it out. Marking rubric for the presentation. You can see that. That's up on Canvas. Pretty standard stuff. Now, Canvas tour. Do you want to talk about? Nope. No, don't want to talk about Canvas. Oops, no. Did you want to have a look at that?
Not at Canvas. No? I've just got my rules of engagement.
Oh, rules of engagement. Okay, go.
Yeah. Okay.
Yeah. This is Anna, by the way.
Hi.
Anna has been working all year for you guys, and she has done a fantastic job. I want you to give her a round of applause right now to start. Thank you, Anna. Now, what words of wisdom do you have for these people?
Well, it's really rules of engagement. And you've already mentioned the first one. For me, the most important one. I've spent almost a year trying to sort out these agency meetings for you. You need to contact them today. They are all expecting to hear from you today to reconfirm the meetings I've set up for you. I've had an email just in the last 10 minutes going, we haven't heard from our students yet. Is it still happening? So they're really waiting to hear from you today. So today at 3 o'clock, 3:30, get on to that. Don't ask them to change the times and dates unless they bring it up. They've already been asked that, and what is in your meeting schedules is what is most convenient for them. Boyd's already said again, don't go to them and say, this is what our campaign is, how can you help us out with that? That's not the idea. They will have an agenda, they have their own work. You need to go and listen to them, learn from them, learn about from their perspectives, who they deal with, the issues they see, and that sort of thing. So don't get them to help you with your campaign. Learn from them and put that into your campaign. Respect the time that they've given up to you. We've had reports in the last few years, agencies emailing me saying the students who came, they weren't engaged, they weren't listening, we don't want to do this again. You're representing the university, so represent it well. If you have Zoom meetings, don't Zoom people in your pyjamas. And because there's only 2 or 3 of you going to each meeting, whether it's Zoom or face-to-face, or especially if it's Zoom, don't have the rest of your team in the room behind you, because agencies feel like the rest of you aren't engaged with what they're saying, so make sure you take that meeting kind of somewhere else. Keep looking at the meeting schedules that are on Canvas for your team. They are always being updated. I've updated 3 or 4 of them already 3 or 4 times today. So don't think that if you download it today and call them all, that's how it's going to sit for the rest of the week. Don't email me via Canvas. I don't look there. Email me directly if you need to. What else? Yeah, don't Zoom in your pyjamas. So yeah, that's about it. Anything with absences or anything like that, emails need to go to Boyd. CC me in, but I'm not going to make a call on that. He has to do that. And you guys here in Auckland, if you need rooms, we do have some available. None of them will fit all of you in there, but email me before 7 p.m. and I will try and get you a room or rooms to work in during the days. But I'll just need, your name, your team's name, how long you want a room for. But call your agencies today.
Okay, thanks. And all this stuff is on Canvas. You guys will be familiar with Canvas. We won't give a Canvas tour. All right, now, folks, I'm going to go through a few models and paradigms and frameworks just to help you see problems in different ways and to see an issue. So these are mental models, basically. And these are very valuable. There's nothing more valuable than a good theory or framework or mental model if it's going to help you work through a tough problem. So all models are wrong, but some are useful. All models are just representations of reality. They're not reality, but some of them are useful to help you think it through. And you can use one or more of these models to fit the purpose of your campaign. So this has already been mentioned. That must have been Jin, I think, that mentioned Te Whare Tapawha from Tā Mason Jury, the different aspects of health. We focus, and you focus, I'm sure, mainly on the physical health, but don't forget there's many other types of health that affect a person and the environment and land and people around them. So pay attention to those. And those are just as important. The 3 Ps, partnership, participation, protection, they might be getting a bit old hat now. This is how the Ministry of Health interpreted the treaty for its use. There's now more of a movement to talk about taking the actual articles of the treaty and thinking about how they can be interpreted, especially for any Crown Maori relationships. But use those principles and those articles as well. Disease characteristics. So this is kind of epidemiology. Patterns of the disease. This is the kind of COVID pictures that we had early on. Patterns of disease tell you something about the underlying structures, about what's driving this. When Penny started her talk, she had a picture of an iceberg. And I know exactly why she had the picture of an iceberg. She didn't talk about it, but she had the picture of the iceberg because that is a way of showing, I guess, in systems thinking, the difference between the visible events, the stuff above the surface that you see that ends up coming through the hospital doors or that you can engage with, versus all the stuff below, all the structures below. And so if you look just below the surface and you do a bit of epidemiology, you come up with patterns like this. That gives you hints towards the structures deep below that and even deeper. And right down at the bottom of any model, of any system, it is driven by any man-made system, human-made system, is driven by the values and the mental models of that, of the people designing that. So if I take the food system, for example, the food system creates a whole lot of diabetes, a whole lot of obesity, a whole lot of chronic diseases. It makes our waterways dirty, it creates half of our carbon emissions, and it makes us a rich country. And it creates a lot of food insecurity and social inequity. A whole lot of bad things and good things. That is the food system working perfectly as designed. All systems work perfectly as designed. So the problem is a design problem because the system is working perfectly. And it comes down to the mental model of what we think food is all about. And if you treat food like an economic commodity, in other words, people make money, get profits, we get export receipts by feeding people who can afford to pay for it. If you treat food as an economic commodity, you get what we've got. And so if we want to redesign the food system, we have to think right back to the mental model. So right at the base of that iceberg that Penny showed is mental models around a system, and that's true for the health system that you're operating in. All right, thinking upstream, there's a little YouTube there. If you don't know what thinking upstream means by the end of this, then I consider this a complete failure of a course. We need to think about, who's pushing the kids in the river instead of pulling them out all the time, and the three speakers talked about that today. Fence at the top of the clip. Look at that little YouTube clip. It's enlightening. Understanding equity and equality. I'm sure you've been through this a lot in your course, but you will need to build this into your thinking and into your campaign. And the assessors will want to see that you've thought about that. The difference between what you do in your clinical world about helping individuals carry their health burden up a steep cliff, up a steep slope, versus what society can do to make that effort easier by reducing the negative conditions or the conditions within society that makes this a difficult job. So we try to make healthy choices, easy choices, as well as encouraging individuals to make those healthy choices. So this is the socio-ecological model. You've seen this a couple of times already. I'm sure you've encountered it within your teaching. Individuals at the centre with their constitutional factors, lifestyle factors, their social networks, all of the settings that they engage with, the work environment, education environment and so on, and then the wider socio-economic, cultural, environmental conditions and so on. So that is an extremely useful model. This is the 1991 version. It came actually out in the late 70s from I think Jin put it up early, Bronfemin or something like that, some German name. Anyway, it's been around for a long time. It's an extremely useful model. So when you've got a person who is in front of you with diabetes, you are thinking, what is it about that person's age and sex and other constitutional factors, their genes or whatever, their individual lifestyle factors, their physical activity, their diet, who they're linked with, their family is, the wider social and cultural environmental conditions. Really helpful for you as clinicians to understand that person. But if you want to ask the question about why is this world, the prevalence of diabetes and obesity in every single country in the world going like this, then you can't look at an individualistic model. You have to turn it inside out. So here's this individual-centric model, which is very useful in a clinical setting. But if you want to understand population health and especially global health, turn the thing inside out. Put our natural systems at the centre, that's what we depend on. And then you've got your man-made systems around that. And the most important ring, the most powerful ring, is the one right at the centre, which is the governance, Who is making the decisions? Who is making the design? Who designed the racist rollout that I think Hirimoa mentioned? You know, who designed that? So there's something, and somebody pulled that lever, and that happened. That's how we're going to do the vaccine rollout. Turned out to be racist, and the community organisations jumped up and down, and then finally the government said, oh well, here we are, here's the vaccine and you work it out, and they did, and the Maori and Pacific vaccinations went right up. So whoever's got the hands on the power, who's making the decisions, the policies, the economics, those are the people that can really make a difference, because they're at the design phase of whatever the system is. And then these are the things, a little bit like the whare tapawha, that we want human health and well-being and social equity and economic prosperity and ecological health and well-being. Those are the things we want from our systems, and we're not getting them. The Ottawa Charter, 1986, long before most of you guys were born, an oldie but a goodie. And quite a few groups use this to structure what their actions are going to be, strengthening community action, personal skills, supportive environments, reorienting. It's not just reorienting health services, but reorienting systems and building public policy. So that's been around for a while. Program logic, this is another way to think about creating a campaign, thinking about creating a project. You can use this structure to help structure it. So you will have a situation assessment that you will have done in the first couple of days, and then you've got your priorities and your mission and your vision. What is it you want this campaign to achieve? And to achieve that, you need a whole bunch of inputs, staff and people and money and knowledge and expertise, and then think about how this is going to be implemented and what impact it's going to have. So that kind of linear process of thinking about project development and project implementation. Oh, there's the iceberg. Okay. Events on the top, that's what you see all the time. That's what everybody jumps to when they say, what should we do about it? They say, change the stuff we can see. So if we take sorry to keep going back to the food examples, but that's what I do. But school food is selling junk food in the canteen. That's pretty bad for health. Let's do an intervention. Let's change the menu, because that's what we see. We see what's on offer in the canteen. That's the most visible and the weakest thing you can do, because you get pushback. And the kids won't like it, the parents won't like it, the canteen owner won't like it, and you'll get all sorts of pushback. If you go in deeper and look at the patterns and the structures, what are the policies and so on, and you get right down to the mental models. If you go into that school and across the front of the school it says, we are providing the best environment for your children to live and learn. If that's part of the school motto, the school values, and then you go to the tuck shop. Oh, shut up. Then I speak too loudly for Siri. Then you go and look at the school tuck shop and you see it's producing junk food. And then you look at the banner across the front of the school, it's inconsistent. And so much easier to change the things that are visible if the mental model about what we're doing here it has buy-in from everyone. And so then it's much easier to change the canteen menu. And this is another challenging bit, event-oriented thinking versus systems thinking. We tend to think in linear lines about the causes of the cause of the cause. We go back linearly, but almost all causes of wicked problems are in circles. They're in loops. Now you people, you're in 5th year, and you have spent 5 years already learning a hell of a lot about complex adaptive systems in your physiology. about the endocrine system and the cardiovascular system and the renal system. They are all amazingly intricate, complex, adaptive systems full of feedback loops, largely negative feedback loops, to keep homeostasis. And you're now working and getting experience in a healthcare system, which is a complex adaptive system. And the things that are coming through the door are all products of societal complex adaptive systems. And yet nowhere in your course have you learned about what systems are or do, which I think is a bit of a failing. It doesn't help us. We need to be able to think in those systemic terms to be able to understand the problems we're dealing with. Even if you're trying to get something new happening within the healthcare system on the wards and within your cardiology clinics or whatever, that requires systems change. If you don't understand the nature of systems and how systems change and respond, where their resistance is, where their inertia is, then it's very hard to change systems. So we're not going to go into that in too much detail, but just be aware of that. All right, social determinants of health. We even saw this picture up there, Closing the Gap, report by Sir Michael Marmot. So it's called the social determinants of health, and I'm not a great fan of the word social, I have to say, because that feels like it's of the people as opposed to societal, which is of the structures. And yes, people determine what the structures are, but there's lots more iterations, I guess, of this, like the commercial determinants of health, the political determinants of health, economic determinants of health, cultural determinants of health, religious determinants of health. All of these aspects are really important. And is it determinants of health, or in the commercial sense, it's often determinants of disease and death. Okay. Collective impact is a concept that I think you need to carry with you in this week. The temptation in developing your campaign is to say, okay, we've got $500,000 and we're going to do this, and we're going to do some advocacy on this strategy, and we're going to build some materials, and we're going to try to get a policy champion to carry this through. And it's we. Who is we? Who is we? Is that a bunch of fifth-year medical students that's going to get this through? Who's going to change this complex adaptive system? You need to be able to think about what is the collective within society, these various agencies. Who's the $500,000 going to go to? Who's going to take these people? Who's got the mandate? Who's got the expertise and knowledge? How can this be applied in a collective way? This is not 10 fifth-year medical students carrying a campaign forward over the next 3 years to be able to get this thing implemented. So who's going to be who are going to be the allies? Who are going to be the leaders in this? Thinking collectively, okay? So this is a way of doing collective impact. When you're pulling different groups together, the first thing is a clear common agenda, and that's actually sometimes a job of work. So sometimes you might be able to see there is, all these agencies out there, and we really think that they will be able to contribute to the campaign, but the first thing we need to do is have a big hui to get them together to put this agenda on the table and get them to agree about what their common mission is, and then you've got them on board and they're collectively moving towards that. What are the shared measurements? You're going to be asked about evaluation. How do you know you're going to how that's going to be a worthwhile spending of $500,000? Is that going to make any difference? Mutually reinforcing activities. So this is, here's one agency that's going to be our best to do this stuff. Here's another agency that's going to do this stuff. Here's a group of people over here. Here's some academics who can contribute the research. And how do they get connected? How they mutually reinforce? That's part of the purpose of getting the common agenda. Continuous communication and a backbone support. So the backbone support doesn't have to be the group that's doing everything. It can be just a coordinating group. So, for example, at the moment we're trying to get some collective impact happening in Hawke's Bay about reorienting the food system within Hawke's Bay so that it better delivers on health and food insecurity, as well as maintaining prosperity, and it better delivers on its ecological footprint. So how do you do that? You get you get the important growers, you get the environment people, you get the councils, you get the schools, you get all different groups in the table, around the table. But somebody's got to do that coordination. There has to be an NGO out there or a group or so-and-so that's doing it. At the moment, we're running the backbone organisation through EIT, which is the Eastern Institute of Technology. That's a tertiary institution. That may not be the best. But it might be better to be an NGO or a regional council or something. So coordination is important. All these things need to be incorporated into your costs and your thinking. All right, so questions that you might have, bring them to the 12 o'clock Zoom, feed them through to your person who's going to do that. Any content questions, feed them through to your topic experts. Any challenges you have around the team management or developing the strategy, then go to your facilitator or bring those questions to me. Anything around student absences or student issues, you need to report them to me and to Anna. So I think that's almost it. The final word, of course, is to enjoy it. You will learn a lot. I'll be very disappointed if you don't learn a lot. The things I think that you will learn are, number one, about working in groups. Number two, about the complexity and degree of difficulty of these public health problems you've been given. And number three is the challenge of pulling something together that's actually going to make a difference. So I hope you learn all those things. And before we go, any comments or questions? No? We all okay? All right, so we're going to start with the forming at 3 o'clock with your facilitators. All the best, people. Enjoy it, and we'll see you on Friday. Kia ora.